Shall we connect to the case then?
Yeah,
I think we are waiting.
So 1 second, sir. Once we put the live, we'll declare Sridhar sir will do opening remarks. Over to you, sir.
All right. Then we'll go ahead.
We are on live, sir.
Sridhar sir, you can do the opening remarks. Good evening to all of you. Welcome to second day IPS Summit conference. Today, right now, we have two live case transmissions. One from Madurai, operator Dr. Selvamani. You are all very familiar with him. The another operator, Dr. Arun Kalyan Sundaram from Prominent Hospital, Chennai. Arun also very well known to everyone. He's a very CTO expert. And these two guys, they don't need any introduction. Both are very familiar to not only nationally, even internationally. So with this brief introduction, let us move on to live case transmissions. Ravi, are you connecting first to Salomani or Arun?
MMHRC, sir.
Yeah. So first transmission from MMHRC, that is from Madurai. Now, today we have a expert panel member, Dr. Gopal Krishna and Dr. Jabir. Both will be giving expert comments as well as they will be moderating the session. Dr. Selvamani, welcome. Are you able to hear?
Good evening, Sridhar.
Good evening.
Nice seeing you. And,
yeah, very nice to see you in action.
Come on, sir.
Selvamani, good evening.
As usual, you always keep some educative, you will be interesting and academic case.
Yeah, today we have planned some interesting case. I don't know, probably it might be interesting for you or very simple. And we will go through the history also. And I think I have with me a lot of our friends around. Dr. Tanu, Rajiv, Rakesh and Ganeshan is around. And we have our entire Cath Lab team here. And we started off with this, and then I think Tanu, you can present the case, and we'll go there.
For more than 30 years, Meenakshi Mission Hospital, Madurai, has been the backbone of the health of South Tamil Nadu. With 45 departments and 1,000+ beds, it is the numero uno multi-speciality hospital in the temple city of Madurai. Bringing world-class medical facility to the common man's doorstep is our motto. One such fine example is our cardiology department. Meenakshi Mission Hospital is the first hospital in South Tamil Nadu with 3 fixed cath lab and an electrophysiology laboratory with 3D navigation technology.
Oh, not unexpected.
It is equipped with the state-of-the-art intravascular ultrasound integration and optical coherence tomography. With this, we can proudly say our heart is big, our heart is young, and our heart is strong.
So our case is a 73-year-old male who is a known diabetic and hypertensive on medical management, who presented to an outside hospital with complaints of chest pain and dyspnea since the past 5 days. He was diagnosed as an NSTEMI and was treated conservatively there, and angiogram done outside and advised for CABG and CBG. So he came to us for a second opinion. So his lab reports are normal. ECG sinus rhythm and with T inversions in 1 AVL and V4 to V6. And now our echo showed mild LV dysfunction with a hypokinetic anterior wall and lateral wall. Next.
So now basically a 74-year-old male who had a tropi positive chest pain admitted outside, and he underwent an angiogram there. And you see the angiogram. Can you see the angiogram now?
Yeah, able to see.
Yes.
Yeah, this is the right coronary that you are seeing. Next. So this is a left system what he is having. So right was non-dominant and left it's a dominant circumflex artery there. And then you see it is some calcified LAD vessel there. ostial LAD, you see that there is a disease there. Next. And this is the AP cranial view. There is a moderate to large diagonal vessel which has almost 99% or 90% stenosis there. And after the diagonal, there is a LAD disease there. Next. And this is the ostial LAD lesion that you see there. Next. This is the iliacaudal view. Next. And this is what is, you can again run the angio. And this is where we have this patient now. So what to do for this patient now? Actually, he was referred for CABG. And anyhow, they were not very keen in CABG, and they came to us for a second opinion. So I have posted this case, and we have experts there, Sridhar, Jabir, and then Gopalakrishnan sir. And you can just give your opinion, like what to do for this angiogram.
Jabir, you can comment, Dr. Jabir.
Look, this is a left main disease with a wide bifurcation ankle, a little shorter left main, but I think it is 12 millimeter left main where we can do a port if required, and a tight ostial disease. It seems to be an 80% ostial disease with calcification. And down the line, there is astride the diagonal, there is a significant lesion, seems to be 70-80% lesion of the LAD. And diagonal is having a significant lesion with almost a 2.25 to 2.5 millimeter diagonal. Now the question is how to deal with this lesion. It's a dominant circumflex and non-dominant RCA. If we are tackling the LAD by angioplasty, we have to tackle the ostial lesion. We have to tackle the mid-LAD lesion also. Then if the mid-LAD lesion we are tackling, whether to look at the diagonal also, whether we have to tackle the diagonal. That diagonal supplies a significant area. So if we are tackling the diagonal, then we have to do a bifurcation for the LAD D1, then followed by a bifurcation, possibly, since it is a wide ankle, but a little problem because of the dominant circumflex, but still I'll consider a provisional approach for the left main. But at the same time, LAD D1 requires a committed two-stent technique, and the calcium have to be tackled. So it's a pretty complex disease, and I would like to do it with the help or optimize it with an imaging. So the LAD needs to be tackled. LAD D1 bifurcation has to be tackled. So the LAD D1 bifurcation, its ankle is somewhere around 70-80 degrees, a tap or a DK crush. That depends upon the operator. But at the same time, we have to do a calcium tackling or a calcium modification, the modification of the LAD. So it is a LAD D1 bifurcation at tap versus a DK crush. The calcium modification, I would like to run have a run of a 1.5 millimeter bar of rota. Then the LAD circumflex, we do a provisional stenting. If required, we have to do a circumflex. We may have to look at the imaging. If there are no struts after stenting from the left main to LAD, it requires a left main to LAD stenting. If there is no struts across the LAD circumflex, if the circumflex ostium is pretty okay with the imaging, we may leave it alone. And if there is a significant issue at the circumflex ostium, we may tackle the circumflex. That would be my approach.
Dr. Gopal Krishna. So to me, I think because the LAD ostium, it's very significant. As Dr. Jabir said, the provisional stenting of the LM bifurcation and the diagonal and LAD bifurcation, definitely diagonal is a very big branch. It has to be addressed. Two-stent technique, because the diagonal is very, very critical. There is a moderate disease of LAD D1 that after diagonal origin, there is a moderate disease and reasonably calcified. I prefer to do the intravascular imaging first. I will assess the calcium, and if it is a superficial calcium, if the depth is more than 0.5 mm, length more than 5 mm, arc is more than 180 degrees, like a moderate to severe, like a 270 to 360 degrees, definitely I will run the rota. Suppose if the imaging doesn't show the calcium arc, that the arc is less than 180 degrees, depth is less than 0.5 mm, I don't do regular NC would do well. So that's the reason always, my opinion, I would prefer the IVAS run or OCT run, see the calcium assessment, and for LM bifurcation, preferable to do the provisional stenting, LED D1 two-stent technique. And if needed, if there is side branch pinching of the LM bifurcation is there, I would like to do the FFR of the LCX. If needed, I will keep the provisional T-tap stenting as an option.
Okay.
I do fully agree with Sridhar. That is, if there is an LED circumflex bifurcation, it's better. I think it is preferable to do anyway, there will be an imaging guided. I'm sure that Shalvan is going to do an imaging guided PCI. We'll do an FFR and see if the FFR is less than 0.8, we can leave it alone.
Correct.
As Dr. Jabir said, the LCX closure is very, very unlikely because the LCX is looking big, very wide open, and angle is also favorable. I think provisional stenting would do well for that patient.
Yeah.
Dr. Krishna, anything you want to add?
Yeah, that's the proximal left main bifurcation is 0, 1, 0, and the distal is 0, 1, 1. And one thing is, my question is similar to my patient yesterday. Are we going to do it as 2 lesions or 1 single lesion? So there is a large normal segment which is about, looks like a 5 millimeter in between the 2 lesions. That looks normal. If what ultra OCT gives us, I don't know. It looks like a normal segment. And another point is, there is another diagonal which is not big but moderate sized at the first lesion, very early D1, apart from the second diagonal. That, are we going to ignore it, just leave it alone and think of, because the second diagonal is bigger, we got to tackle that. That's another point. Definitely that kind of lesion, distal lesion, needs a 2-stent strategy if we are going ahead with PCI and provisional for this thing. But it looks like we are dealing with a 4.5 5 proximal LED, a very huge LED.
Right, sir. But this is what I was also thinking right from the beginning. And but off late, what we are doing is, most of the time we go for physiology as well as imaging. So I thought that actually initial my plan was to use 1 or 2 stent. That is, as Gopal Krishnan sir was saying, use a long stent from left main into that mid LAD, and in the diagonal do a probably DK crush or mini crush, something like that. And that was my idea. That is why I posted this case. And generally today, as we do physiology, I did a FFR now to start with into the LAD. And to my surprise, what is happening is the similar surprises have come there. The entire LAD, you can show the FFR now. Well, we did both RFR and FFR. Both in the entire LAD, it is negative. That means FFR is 0.94, RFR is also 0.96 or something like that. Show the FFR and RFR there. அது run பண்ணு அன்பு. You can show the live. See, what I did is I have done a continuous this FFR into this LAD at the distal point of the LAD. In the entire LAD, the FFR is negative. So this is one big lesson that what we have learned. Previously, whatever we were looking like this at 80% in the mid LAD and ostium, this was definitely looking very critical. Actually, that was the reason I posted this case. But here, when I put a FFR, this for the last some time, we have been doing like this for all major cases. We do functional study, and we are planning, we are doing one study also in this. And this FFR turns out to be negative in the entire LAD. So both RFR and FFR is negative in LAD till the tip of the LAD now. So what is the next option is now? I think if FFR is negative, should we do anything to that LAD now?
If FFR is negative, preferable not to intervene, because as per the trials like a FAME trial or DIFFER trial, if you compare like even 10 years data is available, those who underwent a PCI and those who did not undergo deferred, almost 2.2 versus 12.2. That is a major, the MACE rate is very, very high. That's the reason, based upon these trials, better not to go for stenting. That's the reason even recent SKY recommendations, even in 90% lesions, 70 to 90% lesions, the FFR may become negative in 15 to 20% of the patients. So they advise very clearly, even 70 to 90% lesions should be interrogated with FFR if there is no classical symptoms, when there is no angio and clinical correlation. But when you are doing the FFR, use the advantage of FFR. Physiological, it's not significant. We are not supposed to touch the FFR because LAD diagonal appears to be like a just, it's having a at the origin disease-free segment. Just to at the ostia, just to do the stenting of the diagonal, I think that would be the right strategy based upon the physiology. And this case definitely illustrates 80 to 90% lesion of the ostial LAD. Negative, and intermediate lesion is negative. And even if you do the procedures, we are not going to achieve anything. The MACE rate will be much more if you are doing. If you are leaving, MACE rate will be lesser.
Yeah, you are exactly correct. It's a very complex procedure that we were planning. And but not only this, recently we have a lot of cases where when you integrate physiology, that is FFR, many times the complex case becomes very simple. And but what I have done is, I have done a OCT of LAD. You can look at the OCT in the LAD, what it is happening now. So can you show the OCT there? Are you seeing the OCT? Yeah. So this is the run in the LAD, and from distal of the part, and you can you see the angio co-registration also there? Yeah.
Yes, yes,
And
yes.
this is a run there in the
Yeah.
LAD, as you said. Definitely, it is looking very significant, and the minimal lumen area in this just after the diagonal in the LAD is only 1.75. And there is some amount of calcium. You see plenty of calcium there. You can see the calcium here. And when you just come there below in the LAD, it is definitely a calcified lesion. And there is a lot of, when you come up above the, this is the diagonal bifurcation there, LAD diagonal bifurcation. And when you just come up above the diagonal there, that's again a calcified LAD, but the lumen area and all is very good. It is somewhere around you 7.5, 8 there, calcified vessel. And when you come to the proximal LAD now, and this is the proximal LAD. When you come there, the lumen area, what we are getting is somewhere around 3.72. That is the minimal lumen area in the osteoproximal LAD. So, but the FFR is negative, and usually OCT correlation for FFR is usually, if it is lumen is less than 1.9, usually FFR is positive. But for non-left main area, using imaging alone is not so applicable. We don't have much of evidence. But for correlation, that is what is suggested. Less than 1.9 should be significantly FFR positive. But here in this case, we have done a FFR, we have done RFR, both is negative. FFR is not only, but it is somewhere around 0.9492. So it is so high, it is not even 8.5 or 8.4, not even borderline. It is so much, and it is definitely a complex procedure if we are doing, that is ostial LAD or across the left main, and again a bifurcation lesion in the mid LAD. So this is the OCT finding and FFR finding. Now, do you have any change of idea, sir? You want to suggest me? Like, I accept that we'll treat the diagonal, whether to treat just at the ostium or boom technique or crossover from LAD into the diagonal, that we will discuss. But apart from this, with this OCT finding, a lumen area of around 3.27 at the osteoproximal LAD and around 1.78 in the mid LAD, and some calcified lesions here. Any other suggestions, sir?
Actually, there is no good correlation between the FFR and OCT. Different studies have quoted different areas. Some studies have quoted 2.5 square mm, some studies have showed 1.5, 1.9, and some studies showed 3 square mm. But there is no exact correlation. That's the reason, as of now, there is no validated study. So like a IVAS and LM, there is some correlation. Like if like less than 4.5 in Asians, if it like a Europeans less than 6 square mm, the JASTI group, these groups have recommended very clearly. But there also, if you take the OCT, 10 to 15% smaller, this is for left main, but non-left main, as you said, there's no a very good suggestive report to say that this is the definite indication if the OCT is less than this. Only some cases where like a Forza study is there. In the Forza study also, they have taken the criteria like a lipid-rich plaque, thin cap fibroathetomata, macrophages, those things they have considered. But here a calcified plaque, I don't recommend anything because the DEFA trial definitely showed the MACE rate is much more if you do the intervention when the FFR is negative. And even FAME trial also has shown same thing. I prefer only diagonal intervention. And if you want to do the like a ostial boom technique, if you want, you can use the boom technique. I think that would be the preferable.
I fully agree with Sridhar, because here it is not even not a borderline case. It is 0.94. That is what we are aiming after stenting.
Yeah.
That is what we are aiming as the perfect FFR after stenting. So we are having a physiological value or the flow reserve which is similar to that after a perfect stenting. So then there is no indication or no justification for doing an angioplasty there. As Sridhar said, I think it is better to go ahead with the diagonal angioplasty and leave the LAD. And for OCT, we don't have any recommendation regarding doing OCT with doing indication for doing a lesion with the OCT lesion characteristics or even the lesion significance or severity. It's all based on physiology. Physiologically, it is 0.94 means there is no justification for doing an angioplasty, especially a complex procedure.
And,
yeah, have you, Dr. Salmani, have you done an OCT for diagonal, seeing there is a landing zone? If there is no landing zone in the diagonal at the origin, is it better to manage him medically doing a diagonal alone without a significant LAD disease? That should be an option also.
in diagonal, as you said, what is the mortality benefit in doing angioplasty to diagonal? That is what is it. But anyhow, it is a significant FFR positive lesion and moderate to large size diagonal there. And I have done a OCT to diagonal also. I think you are seeing that.
Yeah.
But that catheter was logging distally, little bit of clearance was lesser. But anyhow, it's a big diagonal. And you look at this, this is the zone where the diagonal and the LAD ostium it is. So now this is the LAD what we are seeing, this spot, and this is the diagonal spot. And there is a landing zone there. And the angle to LAD is almost 90 degrees also there. And we have a good landing zone at the ostium of the diagonal. That is one thing. But many times what I have done is if it's a large diagonal, you might miss the ostium. So generally what I do is I have done a crossover from LAD into the diagonal. But here, since there is a landing zone, we can consider more of only isolated diagonal stenting. And I am at this stage, whatever you people suggest, I think I will think over and then go ahead and do it, and probably will take a decision.
Salomani, meanwhile, we'll go to Arun and then we'll come back.
So then I will just set the ostium of the diagonal, and you can come back to me now.
Yeah, sure. A very nice case, and
yeah, it is for me also. It was really a surprise.
yeah,
Because, but previously also we had few cases like this. He was actually referred for bypass surgery, looking at the ostial LAD, tight stenosis, and some mid LAD diagonal. And I think it's good for the patient that probably he should do well. We'll try to do the
interventional cardiology. Expect the unexpected.
Yes, sir. That is what is there. So we'll try to do that for the patient, sir. And you can come back to me later after seeing Arun.
Okay.
Probably Arun must be doing a very complex case there. Come.
Arun, welcome, Arun. Good evening.
Hi.
Very nice to see you.
Likewise, good to see you guys. We have been seeing you for a while, so good to see you.
Your images are very bright like you. I think very high resolution camera, I think. Is it right? Why?
Yeah, probably. I don't know.
You can go ahead.
Can we load the PowerPoint, please, so that we can just go over the case?
Arun.
Yeah.
We have a Dr. Jabir and Dr. Gopal Krishna.
Hey, Dr. Gopal Krishna. Hi, Dr. Jabir. And hi, Dr. Sridhar, of course. And who else is there?
Dr. Gopal Krishna.
Hi, Kalyan. How are you?
I'm good.
All right. As Sridhar said, yours is an excellent project. It's something like a high definition camera.
Yeah.
No, I'll make sure I compliment the AV team.
Pretty clear.
Yeah, we noticed that the previous.
Yeah, it's excellent. Very good.
Okay. So guys, can we have the PowerPoint, please? Yeah. So, I'm gonna just pull this and put this back in the guide apart pannituma. Okay, good. So guys, it's a 73-year-old male patient, like the typical person who on end-stage renal dialysis, diabetic, etc., preserved EF, symptomatic. Next slide, please. So he's got 3-vessel CTO. So he's got a LAD CTO, he's got a LAD CTO, a CIRC CTO, and a RCA CTO. I hope you guys can see that. So he was advised bypass surgery, but then the surgeon, and after an informed discussion, given the mortality rate or the predicted mortality rate, they decided not to go for surgery. And so multi-vessel PCI was felt to be like the next option. So we, about 4 weeks ago, go to the next slide, please. We did the LAD CTO. Next slide. And the CIRC CTO, both are done. LAD we did antegrade wire escalation. CIRC was done through an epicardial retrograde. And then we kind of decided we'll stage the RCA CTO. So that's kind of where we are at today. And we'll then kind of walk you through the whole thing. So we have bifemoral access. Can you guys show the screen, please? Guys? Okay. They don't need to see us. Okay. So that's, bifemoral. That's kind of what we're dealing with. We just did a quick, that's the LAD. And I'll just show you this RCA. It's pretty much close to ostium. We have a tough time with the backup issue. Given that we had a usable collateral, the plan was to go and go retrograde right off the bat. So what we did was got into a septal, and then decided to jailbreak it. So took a 1.5 balloon, opened up the strut, Corsair. I don't know if this is the run, but whatever. Okay, I think that might be the run. So long story short, usable collateral, went into the PDA. Yeah, I guess, sorry. So I'll let this play for a second, because this is the actual fluorosave of the wiring, I think. So again, given that I was fairly confident that there were options. I decided to surf it. I didn't really know which collateral I took. There. All right. Okay. Boom. And now we are there. Okay. So, well, I'm sorry. Maybe this was the run. Okay. Whatever. So we are here. The rest of it was just wire. This went up pretty fast. So we are right now in the distal RCA. I mean, we have kind of gone all the way to the proximal RCA. We had a little bit of trouble getting the Corsair down. So we took it out, balloon dilated the whole thing with a 1-2 mini trek. So, and then I'm going to let this play. So then the Corsair just slid right through. So once this was done, so the initial plan was we thought, okay, this might be a retrograde true-to-true wire. So that was what was done. So I used a Pilot 200. I mean, I kind of thought, okay, this is not too long. I had an Amplatz. I protected this thing. And there, it looked like it went true to true. And it kind of gave, all right? So the problem was the Corsair didn't act free. Now, when it's this close to the ostium, it's possible that I might have created pretty much a neo-ostium. I did not like the way, I mean, I tried briefly to snare it, but the way the retrograde wire was behaving was just not right. So, and given that I already have a Corsair channel, what I decided was I'm just going to come in and wire it. So, got the microcatheter back. That's yeah, I'll just let this play. So I just got an anti-grade Corsair. This is another part, a new Pilot 200. Just ended up wiring it because I already have a Corsair channel. So once this was done, ballooned it, exchanged for a workhorse wire. That's important. And then we did an OCT. Oh yeah, so I think this is where we're exchanging for a workhorse wire. And ballooned it more. So this was a 2.5 NC balloon. Interestingly, although the patient is like, is a dialysis patient and has a lot of calcium, you never know where the calcium is, right? So, I mean, we're kind of hoping it's adventitial. If it gives pretty well, then so be it. And it looked like it did. So then we got an OCT run done. So guys, can we show the OCT, the first OCT run, please? Oh, I took out the retrograde stuff. I just made sure the collateral is okay. And I mean, the rest is, now we can talk about the imaging part, which is kind of what this meeting is about. And I got a lot of smart people there, so you can kind of, we didn't go all the way to the distal landing zone. This is like the first OCT run. So I'm going to just let this play. And yeah, Dr. Sridhar, Dr. Gopal, Dr. Jabir. So if one, and this was done with saline. So one of the key things is, oh wait, let me show you that thing. So there's a, where is it gonna? Oh, there we go. Okay. This is kind of an important thing because many times people just assume that you will have to use contrast. As you can see, this is a saline OCT run. So you don't actually need to use contrast. I mean, I could have. I just wanted to do this as a proof of concept because this is a dialysis patient anyways, but it's more for, I guess, education. Can you guys, are you seeing it? You see a lot of calcium there, obviously, as it comes back. Because is it playing or is it not?
Not playing. Just ask them to move it.
Yeah, play it, Shyam, bro. Okay.
Ask him to move the cursor.
Yeah. He's moving now. Sorry, he was playing. Okay.
Just press the cursor and move it.
Can I press the cursor and move
it? Longitudinal, not the upper one. Bottom. Yeah, that one. No, not the upper one. Lower, the bottom horizontal one. Longitudinal view. That vertical line is there, na? Just press that and move it.
So you guys see, so what do you guys think I should do? Yeah, I mean, how should I treat the calcium?
The calcium is very significant only.
Yep.
You can move it. Yeah, here fibrosis, go distally, just run from the beginning. Here,
I mean,
here
there's
is
deep,
significant
lot of calcium, right?
lot of calcium, circumferential calcium is there. Here fibrosis, yeah, you can move further. Here also fibrotic lesion, go move. You can move further.
Okay, we
Same
did one
person.
more. What would you suggest we do at this point?
At that point, definitely it's a significant calcium is there. And I feel if you have open NC also, that will work well.
Okay, since you asked, that's what we did. So that's an open NC trio.
Yeah.
All the way, boom, guys, show the, you can see the angio there, right, guys? Okay, that's OPN. Looks like it's dilating pretty well, right?
Yeah.
I mean, everything's kind of giving. So I just took like still cine so that you guys can see it. So that's distal to proximal. We went like 35, 40. And then I did one more OCT run just because you guys are watching. So, and it's always a good idea to know what has happened post your high pressure inflation. So this, we did it. I want to show this one.
Yeah.
And this is like, I mean, we're pretty much at live. This is what I just did. So we did this as a, hold on, how do I, okay. No, this was a 1:1. Because I had not taken a picture after the OCT run. So, I mean, after the OPN. So I just did it together. I mean, might as well, it's a 1:1. So obviously distally, it's a huge vessel, there's some positive remodeling. I've already dissected somewhat in the mid to, you know, the mid and the interface, I guess, in the distal mid part of the RCA. And there's more. But I mean, I think we have good luminal gain. So what do you think I should do at this point, guys? Oh, and then
you can implant stent. It's nicely dissected and cracks are there, and very well the plaque modification is there. You can move. I think it's you can get away with the stenting. It can expand well.
I think so too.
Yeah.
Okay, who votes for taking
Just
a larger
entire,
NC balloon and dilating a little bit more?
Aaron, ask them to show the entire vessel OCT view.
Can you show him the entire vessel? He can listen to you. He's just doing
just to move that cursor. That yeah, just move it. Yeah, you can see the crack very clearly.
Yeah, exactly.
In the calcium block, you can move it. Still, but
And
it's a
Sridhar,
very
it seems
big
to be
vessel.
well dilated.
Well dilated. You can
And
do.
the bed is. I think the bed is well prepared. And you can go ahead with a stenting.
Yeah.
So I just figured, like, you know, this is where I have a lot of smart people, so I'm going to use them, right? So I haven't done I'm going to do one angio here just to take a look.
Yeah.
And then sizing wise, Kana, can you just show me the distal reference and we'll just take a look at
Huge vessel, almost 4.
It's a 4.
What is the
right?
length of the what is the length of the stent? What is the length of the stent you are using? You may require a pretty long stent, isn't it?
Yeah.
You can measure it with the OCT.
Yeah, it looks like a 3.5. It may lead a 3.5 by 48.
Yeah, 3.548, and then whatever is left in the give me a 3.548, please. I'm gonna leave the like beyond the crux.
How about dilating with a 3.5 NC balloon?
That's kind of what I was getting at. You want to do that? Let's do that. Give me a 3.5 NC. Let's do it.
I would do that. See how it expands.
I like that. I mean, there's no downside. I can use it for post dilation too.
Yeah,
but definitely it will expand well because the OCT is showing the beautiful fractures.
Yeah, it looks pretty good.
It's a very well prepared bed.
Consider using a cutting balloon instead of.
You know, I was thinking about that. There was some discussion about it. I want something that will take care of both fibrosis and calcium. I had an OPN on the shelf. I thought we can kind of. I mean, if I prep the bed with one balloon instead of 2, I'm going to cut down. I mean, that's another, whatever, 30K or something, right? Do I need it? That's the question.
But compared to cutting balloon, the efficacy of the open NC is much more because the open NC, you can go up to 45, 50 atmospheres.
Especially with calcium this much, right? Yeah.
Almost like a rota-like cuts it can create. It's a very high pressure balloon.
I mean,
in fact, I have the IVL guys also back. I mean, which I guess is the same company. So we had everything prepared, but I mean, if this is good enough, then so be it.
I mean, the financial
So
constraint.
guys, Translumina, the panelists told me no need. All right, okay, not me. Okay. Okay, good. Deflate.
Sridhar, there is some amount of deep calcium. Do you think an IVL is really going to help? The lumen size appears pretty good.
But luminal gain is better and fractures are there.
I don't think we need it. Yeah, I agree, guys.
Expand nicely.
Right.
I mean, this is a 3.5 NC and I'm at 12 and it's given
it expands
12,
very well. It
12.
expands very well.
I mean, if we had not had the cuts, if we, I mean, yeah. I mean, this is deflate.
This is 3.5.
Yep.
You see the behavior. It's nicely expanding.
Exactly.
Kalyan, you have got nice pictures with saline.
Yeah. Arun's hands are magical.
Deflate. Huh? Yeah, approximately we'll put a 4.
No, you got really very good high resolution image with saline, just like contrast.
Yeah, I think that was probably the takeaway from the imaging part is you don't need to have contrast.
Yeah, only thing with saline is you need to use a pressure injector.
Yep.
I
use my hands.
Dr. Gopalakrishnan, we all have changed to the pressure injectors. We don't do now hand injections.
I use my hands.
Oh, still you
yeah, it's actually easier because it's less viscous, so it's actually easier to push.
Okay, we all have changed over to the pressure injectors. I don't know what is Sridhar's practice. Sridhar, are you still using hand?
Still I use hands only.
Okay, we are now into the pressure injectors. We were using hands, but now into the pressure injectors.
So, Kalyan, did you get those images with hand injection?
Yeah.
Your hands are pretty strong.
So first one I did, the second one I outsourced to my friend. Hey, by the way, I never introduced Dr. Shyam here. Works with us. Dr. Bhaskar, Mr. Bhaskar, Shyam from Avid, Nasser, Dr. Karthikeyan, who helps us, who is part of the team. Sujan, the nurse. Ramdas, our EMT technician. Selva.
Yeah, the secret.
That's the team. And then we have a lot of other people standing in the back. Dr. Sadhya for, from anesthesia, like if we need to intubate somebody. And my boss, she was here, she left. Okay. So hopefully I can show you the post-stent results. Okay, good. So this is a 3548 Zions expedition. It just sailed. Turn. Ready? Test. Cannot test. Let's.
But I think needs post dilatation with 4 because distally luminal area, luminal diameter is almost 4. 3.9 it's coming distally.
Come back, go in, whatever. Maybe go in a hair. Mid-marker, science. Okay, go up. 11. That's a 3.5. It's opened up really well. So
Yeah,
I'm happy. Okay. Keep a 4 already, guys. Okay, deflect now. We'll just use this for, it's a 48, is it? Okay. One second. I'm gonna just back it up ever so much. ready to test.
It's a very nice case, actually. 3 CTOs deferred
83.
for CABG and definitely
48.
LAD and LCIC opened. It's a very nice case.
28 or 33? Guys, 4 or 28? You guys okay with that?
Yeah, yeah, that would be fine.
Huh?
Yeah, yeah.
Okay. You guys see it, right? Okay, 4 or 28. What the hell? Okay. I'm just going to use this for dilation just to see how it is. Okay. Okay, Arkada. All right, good. So, I mean, the key point is that, I mean, you know, this is a pretty high-end patient, like in terms of equity and like everything else we got to deal with, dialysis, calcium, 3 CTOs. So, I mean, the point is we can provide comparable outcomes to surgery. I mean, if not better, I think, because here I think the landing zones were not that great for LAD. So hopefully, you know, we are able to provide as good a result as surgery at least. I mean, that's when we can, yeah, go ahead and open it. So at least, you know, I think that's good. Hopefully the patient benefits from this. So it's a 4/28. Zynes that's going to go in now. And I'm going to pretty much, I don't have a lot of room, so I'm going to stent pretty much till the ostium. And then we'll kind of go from there. And then post that into the 4/0, I think, NC. Hey guys, go to keep the stent boost ready, whatever that's called, right? Yeah, okay. And just so that you know, we are working at, dude, okay, we are at, I mean, typically we are at 7.5 and a low fluoro setting. And our air karma is 793 milligray, so we're less than a gray. So that's also important while they're talking imaging and radiation, etc. That's good for the patient, good for us. Okay, ready? So now all I care about, like, don't do anything for a second, all right? Okay. Inject panadra. Okay. Okay, distally we are good. Now give me just a puff. Okay, yeah. Okay, I can come back a little bit. And I have room distal, so I'm just gonna. So this is the one time. Okay.
I think slightly you have to come back.
Yeah, and one of the, so this is, I mean, I kind of, since it's my own lab, I just changed my practice. I actually control, I have my control here, right here.
Yeah.
So it's a lot easier for me.
Yeah.
Guys, go in a hair, or are you happy?
Yeah, yeah, I think very comfortable.
You good?
Yeah, yeah.
I'm just going to check one more shot. You're not too far back left. Baski. Approximately no, I don't actually. Where is strut because it's all in case we have ISR, this, that. It's always a good idea. Okay, good. Karthikeyan, enna solreenga? Eduthalama?
I think they're covering the ostium nicely.
Yep. 4/0. Yeah, go up to 12. 12. Deep flight. Good. Store fluoro. Okay, guys. 4/0 NC balloon, please. Inflict 12. I'm just hitting the overlap habit. Okay.
Yeah.
Deep flight. Yeah. Long.
And then we'll go back to Meenakshi.
All right, guys. I'll do a final OCT run just for documentation, and if you want to catch it, that'd be great. If not, we're good. Thank you so much, Dr. Sridhar. Thanks, Mano. Dr. Kabir, Dr. Gopal. Thank you. Thanks for your input. Really appreciate the chance to have participated.
We are going to come back to you.
Oh, okay.
Arun, fantastic. It is great.
Thanks,
great.
guys.
Anyway, coming back to you.
Yeah.
Thank you. All right. Good. Thanks.
Yeah, Selomani.
Okay, good.
Dr. Selomani, we are back.
Yeah. Sridhar,
you can.
as you suggested, I will show you few techniques like what I did and then how we decided. And as you people suggested, since that FFR and OCT lumen areas were significant, were not so significant, we just did not think of doing anything to LED. But diagonal I have stented. And this time what I have done is, I have generally previously I used to do crossover stenting, but now in this OCT we have a new technique called this boom technique. It is nothing very different. Only thing is, with angio co-registration, you can clearly place the stent at the ostium. So that is what I have done. Go back to those sequences now. Come back. Are you seeing the angio?
Yeah.
See.
Able to see.
Yeah. Okay. Just keep it like that. So what I have done is, by using angio co-registration, are you seeing the co-registration OCT?
Yeah.
Yeah.
Yeah, only. Yeah.
Show that. Yeah. See what I have
Zoom
done
it.
is, I have used the angio co-registration, and with the angio co-registration marker, I have placed the stent there.
Sir, sorry to interrupt you. The co-registration was very small. Yeah, now it's visible.
Yeah.
See, you are seeing the angio co-registration now. So what is the advantages? If you use the angiogram, your placement into the precise ostial location is very, very difficult. But when you use OCT, sometimes angiographically you might feel it is not proper. But OCT is a 3D dimension. In this boom study, also, we have demonstrated. You can precisely place the ostium at least by 1 or 2 millimeter, less than 1 millimeter difference in most of the cases. So I used the same technique. So this is the angio co-registration where I have used to place the stent. And with that, now show the angio. And with that, I have placed the stent there exactly and deployed. Next, forward. You show the angio, please. Yeah. Next, forward. Let me rewind the going back forward. Go forward, and then post dilated with 2.75 NC balloon, and this is the angiographic outcome after the stenting. So I have just precisely placed in the ostium of the circumflex, and now I have done a OCT study both inside from the diagonal as well as from the LED. So this is the OCT run from the diagonal. No, this is the OCT run from the LED. This is the OCT run from the diagonal. So when you look at this OCT, although distal stent, I did not take it because it was too deep. And it is a very well expanded stent. And you see here, it is just at the ostium. Look at this point. This is the LED takeoff. And your stent is just ending at the ostium here.
Yeah.
A very, very precise location. Usually, if you use this boom technique, that is angio co-registration, mark the ostium by the OCT, and then you use it and place your stent. Most of the time, it is very, very successful. Maximum, sometimes you might get one thread outside. Apart from that, you will not have any issues. This is the ostium of the diagonal where I have stented, and there is no compromise of the LED there. And when you do this stent rendering, you can see one stent here. One stent is there, just exactly at the ostium we have landed. And this is the advantage of angio co-registration boom technique for osteal localization and placement. And now you can see the run from the that LAD vessel. And when you see that, even in that, in both the thing, one more thing you should notice is this were all last run, and we were looking at a very small vessel. I have removed the PTCA wire, and this OCT run is without the PTCA wire, so that your image clarity is very good and that wire shadow is not there. Because many times your wire shadow might block the ostial locations which you are looking at. So this is the bifurcation area in the LAD. There is no compromise of LAD, and it has only the diagonal has been stented, and the diagonal mouth is very well open there, and absolutely no compromise in the LAD, and nothing has happened to the LAD. And this is the final result in the LAD, where we did not touch the LAD here. Nothing has happened here, and the stent has precisely landed in the diagonal. And with this, look at the opening at the diagonal also. It is almost 3 to 2.85 millimeter opening in the diagonal there. So anything to add, sir?
Actually, you have shown very nicely the boom technique, how the co-registration is useful for precise placement of ostial location. I think you have demonstrated very elegantly, and you also showed the importance of physiological assessment, and even in 90% lesion that LAD ostium FFR is negative, and very nicely done. And you have shown the usefulness of the FFR as well as the imaging. Very great case, and many learning things. As usual, very great case. Congratulations, Dr. Selvamani. Final comments. You can introduce your team or any conclusion if you want to.
With me, I have our good friend Dr. Ganeshan, and we have our senior cath technician Anbu here, and I have two of our fellows here. All of them were very keen, and they were also shocked to see the FFR in this case. Actually, we were planning probably we might require a 7F guide, so we took a 7F guide, and we had taken all stents, and even sometimes rota also was kept ready. And we were thinking of probably we'll have a long complex case, but this has happened not the first time, many times also. Physiology definitely makes very complex thing into a simple thing, and I think that is how we should proceed in future. And one more thing is post procedure FFR also might be useful, and in future probably in times we will be applying all those things in our routine practice.
That FFR guided interventions, MACE risk reduction is not because of the FFR, it's because of the reduction in the number of stents. Unnecessary stenting is avoided. That's the reason MACE rate is becoming low. So, but a great case, and we will move. Thank you very much, and we will move on to.
Nice case, Dr. Selvamani, nice demonstration of FFR value and also the boom technique for osteal placement. Thank you.
Dr. Jabir, you want to add anything? Then we'll.
No, great. It was great because a complex procedure could be avoided with the use of FFR. And I think just like us, you are also shocked seeing the FFR. That's the beauty of the physiology. Excellent, Selvamani. And you could save a lot of things, a lot of money, effort, and a complex procedure. And I am sure that the patient will do well. Thank you, Selvamani. And I think now Madurai is the center of live cases for many of the conferences. Great.
Thank you, sir. Thank you.
Yeah. Bye. Take care. Right. Arun.
Yeah.
Arun, last 5 minutes.
Yeah.
You can show and conclude.
Yeah. So we just did one more OCT run post stenting. 4 hour, we started with the 4 hour. This is again another And I'll show you the final angiogram in just a second.
It's very nicely expanded stent.
Yeah, it looks pretty
Very
good.
well opposed.
I've already, I mean, till the osteomatic photo, high pressure, circular contrast circular. So we'll just show you the pictures, what we did since you left us. Okay, so you saw the stent being deployed, right? So then we just took a 40, that's the one? Yeah. Okay, the 415 NC, oh, that's a stent, right? Okay. And then that's the 40 NC balloon, 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 balloon. Again, okay, that's the result. Okay. We gave some nitro and had a pretty dramatic response. You just saw the OCT. That's where we are at right now. So I'm just going to take some closing shots of the left and then hopefully final shots of the right, and then we go home.
Yeah, you can.
No, I'm done. You
can say closing remarks. It's a great case, Dr. Arun, from your lab, if you want to address.
Thank you very, very much. Really appreciate the opportunity to have participated in IPS. Hi, Pratap. All right, is that the next session? Hi, good to see you. Hi. Thanks, Dr. Gopal. Thanks, Dr. Jaber. Really appreciate it. I should thank the whole team as well as Abbott for having sponsored it. Thank you so much, guys.
Great work, Arun. Great work. We appreciate your work.
Thank you.
Yeah. Then we'll move on to next session, that is challenging scenarios, a case-based approach. Expert panel members, Dr. Pratap Kumar, Dr. Sharat Chandra, Dr. Gopal Krishna, Dr. V.T. Shah, moderator, Dr. Uday Kanolkar. Good evening.
It's Dr. V.K. Shah, sir.
Good evening, Dr. Pratap Kumar.
Yeah, good evening, Sridhar. Thank you for the opportunity again.
I'm most welcome for you always. It's an honor to have you as a CTO expert.
No, actually I could not join for the case because I was stuck in my hospital cath lab. Sorry, actually I could not see the Arun's case.
Yeah. I think we'll move on to the case session. Are they ready?
So everybody is ready, sir. Dr. Pratap is the first presentation, and Dr. Uday, sir, over to you.
Dr. Uday, sir, you can.
Good evening.
You can take over and you can conduct the proceedings, sir.
Thank you very much. A great honor.
Very good evening, sir. Nice to see you, sir.
Good evening. So let's start the new session. The next session being the first presenter for a challenging scenario on case-based approach would be Dr. Pratap Kumar. Nice to see him after a long time. Actually, I have been missing and you have been active. So let's go straight to your case, Dr. Pratap.
Yeah, sir. Actually, I just wanted to share my screen. They are not helping me. It is telling that host disabled attendees screen sharing.
Yes. Let me just look after that.
One moment, sir.
Please allow me to share.
Sir, it's done, sir. Now you can share the screen, sir.
Share the screen, sir.
Yes, right.
Yes, we are on. You can go ahead, Dr. Pratap Kumar.
Okay, sir. Thank you, sir. So it is a 68-year-old politician admitted with recurrent pulmonary edema in another hospital for some time. He had a class 2 dyspnea. Actually, it is a long history patient. 2 years and the diabetes for the last 7 years. And now the patient is actually now it is nearly 5 years back case. Creatinine is 1.8 to 2.4 in various reports. A global LV dysfunction with a 22% EF with a mild to moderate MR. This was the angiogram. Diffuse coronary artery disease, both LAD, circumflex, osteoproximal disease of the circumflex, RCA, a diffuse disease, PD and PLV, all the target vessels are diseased. So the distal LMCA has a 20 to 30% disease, LAD osteal 50% distally diffuse disease, circumflex osteoproximal 90% disease, distal definitely, circ is totally occluded, distal OM filling from with the collaterals, RCA normal, but the PDA occluded from the mid part. Both PDA and PLV are diffusely diseased. This is a suggestion. So we have got, the patient has gone to many places and everybody told nothing is possible. So the patient came to me. This was the history. We decided to do an angioplasty only for a single vessel in recurrent fashion. That means we have to do in a stage fashion. We took a 7 French EBU3 with an filter FC wire. My plan was to open only the occluded circumflex, distal circumflex. We put a wire with the microcatheter. The wire passed. The wire went down. We used a 1.25 to 10 Ryujin balloon. We dilated, just opened up the vessel. I was not sure that what is the size of the vessel earlier. 2 into 12 millimeter balloon, Maverick. I opened up the balloon. This was the result created after the balloon inflation. We had osteoproximal circumflex as well as LED diseases there. We took a 2.5 into 26 or 0 stent that time. This was done in 2017. A balloon inflation, stent is put. But when I checked the osteoproximal part of the circumflex, it was actually diffuse disease. So I decided to put a stent there also. We balloon dilated the proximal part. We put a 4 into 24 abdominal stent. Dilated. We produced a good result in the circumflex area, but LED was a totally diffuse vessel, which I have shown you earlier. Post dilated with a 4.5 millimeter balloon. This was the result created. 4.5 into 12 millimeter at 24 atmosphere, opened the vessel. This was the final result. We stopped here. This was actually done in 2017. After 3 months, the patient actually cardiac function improved from 22% to 45%. And patient wants to do other blocks so that he can expect a normal cardiac function. We decided to do later. By repeat request, I decided to do an angiogram. I saw the angiogram, circ is flowing very well. The proximal circumflex area has showing mild restenosis, but LED was looking like a threat. Distal LED was looking like a threat. We took a 7 French EBU 3.53. We put a filter FC wire. The wire gone down. I was really afraid to take any other balloon than 1.25 millimeter balloon. We dilated. I was not knowing that what exactly will be the reason, because the vessel may get ruptured. 2 into 12 millimeter balloon proximally, dilated. We decided to take a 2.25 into 40 millimeter, decided to stent track. But the major point is actually you have a stent from LMCA to circumflex. So what I have to take is actually a 2 into 12 millimeter balloon in the proximal LED just to create a space for that, which are only 4 atmosphere. But I took a guide liner up to the ostium of the LED. In that, you can actually see that I have taken a stent. If you see, the stent is taken through the guide liner into the distal part. Once the stent is gone, 2.25 into 40 stent, we have a distal disease also. So we decided to take one more stent, another 2.25 into 36, it is the 35 written wrong, 36 stent. So 40 plus 35, again with the help of a guide liner, I took one more stent down. Through the first 40, you should understand there is an LMCA to circ stent. Then we took a 2.25 into 40 and 35. So 76 millimeter stent distally put, dilated. This was the result for the LED. So far, so good. I decided not to do further anything. We decided to stop here and send the patient back. This is the final result. In 2018, July, that is exactly after 1 year, we did a check angio. There was a mild chest discomfort. Patient told gas. TMD not done. Echo cardiac function definitely improved. Patient wants to have an analysis of his coronaries. This was analysis of the coronaries. Coronaries are looking perfect, including the LED vessel, which was actually, we put a 76 millimeter small vessel stenting, and the proximal part of the circumflex as well as the distal circumflex. Similar angio picture of the osteoproximal LED. When we left exactly 9 months back, we decided to go on medical management. Exactly after 9 months, that is in 2019 July, March, patient wanted to have a re-evaluation. We decided to do an angiogram with imaging this time. If significant, we will go ahead with an angioplasty. Angiogram, this time we did an IVUS. IVUS showing the distal LED was, you can see the measurement of area 3.7 millimeter square area. We put a 2.25 millimeter stent. We really got an area on that part. Mid LED reference was okay. This was the area. So we got an proximal LED was a tight disease. This is the proximal circumflex area. Proximal circumflex stent is actually well opposed. At the same time, you have a minimal restenosis. We did a pre-dilatation. The area was definitely low. So we decided to do a tap stenting with a 3.5 into 28 science expedition that time with a balloon there. Pre-dilatation, post-dilatation 3.5 into 12 millimeter balloon in the proximal part because the vessel was 3.5 in the proximal LED. 3.5 balloon into the LED, 4.5 balloon into the circumflex, FKD, then a final pot with a 4.5 millimeter balloon. We got an area of 7.5 millimeter in the proximal LED, which was only 2.5 in the earlier part. We got an osteoproximal LED is 8.2, which is again was very good compared to the 6. LMC was nearly 11 millimeters. This was the final result we got. So the conclusion is actually a refractory angina patient was rejected treatment due to diffuse coronary artery disease. Treating most critical lesions can give freedom from angina. Subsequently, if the patient can be affordable or if you can do an evaluation properly, you can complete the procedures in steps or in series, and that will make the patient happy. For the last 2.5 years, patient is on follow-up, excellently doing well. Exactly 2 weeks back, he asked me, can we do a check angio again? I told, okay, no problem. Thank you very much.
Thank you very much, Dr. Pratap, for an excellent, explicit presentation, stage-wise planning of this coronary artery disease, which was basically a very difficult case. I have with me, with us, Dr. Sharad Chandra, Dr. Gopal Krishna, and Dr. VK Shah on the panel. Before I hand over the screen to them, I would like to ask you one question. Why did you choose the circumflex first and not the LED first in the first attempt?
Correct, sir. Actually, that is a valid question. But what I thought was patient is having mild to moderate MR in the first attempt. So just I wanted to 22% EF with a mild to moderate MR. What I was thinking that if I open the OM vessel, the MR get relieved. So that actually was my critical element. And the lady was looking like a very diffuse vessel with a 1 millimeter vessel. If I can open the circumflex distal, which was actually a CTO segment, I thought patient will do very well. And that was my assumption, and it was definitely proven correct.
Okay, a well-planned decision. We will go ahead and for some comments, Dr. Sharad Chandra is there?
No, sir, we don't have sir with us. We have Dr. VK Shah with us and Dr.
Uday,
Gopal.
Uday, can I make a comment, Uday?
Please,
I'm
please.
VK Shah from us. So this was a very well done case by Pratap and VK from Mumbai.
Yeah, sir.
Excellent result in a diffuse disease of the LED. I was just thinking, in an elderly patient who has a diffuse disease, diabetics, CKD, what would be the outcome of putting these two small stents segment, long stents? What I would have done instead, I would have done with a cutting balloon and then finished off with a drug-eluting balloon to give an optimal result with the drug. And this would avoid restenosis as well as chances of proposition of taking DAPT for a longer term. Here you got away with it, the excellent result, no doubt. But what would be the ideal situation? Because this is an extremely diffuse disease with two very, very long stents in it.
Actually, one point I just wanted to stress you. I could not do an IVUS in this case because of the distal LAD was you cannot take an IVUS catheter that time down. You have taken a 1.25 millimeter and a 1.5 millimeter balloon, then followed which an IVUS taken distally. You will not see that what is the end result or where you have to stop the stent. That is why I could not take an IVUS in that part. So without telling an IVUS, I will not be able to tell that what is the diameter of the vessel, what is the vessel size, whether it is a negative remodeling, or this is actually a real point in this case. So I decided to put a stent because I already dilated the vessel with a 2 millimeter. I was actually afraid even to take a 1.25 millimeter balloon in that case because I just don't know whether I will rupture the vessel. But you told is a valid point. But in a diffuse vessel disease, another point is actually do a cutting balloon and just do a depth and then follow up the case. Luckily, this patient had a follow-up angiogram after 1.5 years, which was showing a completely patent stent in that case. That may not be the result in every case.
Yep. Point well taken, Dr. Pratap. Before we go ahead, I would like to ask two things. One is that you have dilated when you are doing the LAD distally, you have dilated the proximal LAD also.
No, sir. I just took a 2 millimeter balloon with a 4 atmosphere pressure, sir.
Yes.
I just wanted to take a stent because to open the strut only, sir.
Yes. Now, when you have done that, there is a chance that you may create a problem over there, which can give rise to a recoil even if you have taken a 2 millimeter balloon. Now, yes, having done the distal LAD very well, now is the time to take a IVUS shot because now you can take your IVUS further down. So you will get more information. Would that be another strategy?
No, sir, no doubt about, sir. I did not do that time. Actually, I did not do an IVUS that time. Actually, by those time and all, I just wanted to get out of the patient and come out of the cath lab very fast. That was my aim because especially with the guideliner sitting in the LMCA stent, actually the guideliner was sitting from the LMCA to circ. I just kept a guideliner exactly at the ostium of the LAD. That was actually the critical time. I was also afraid because I just wanted to come out. I could have done ideally situation what you suggested is the best thing. That is why the next time when I got a chance, I decided to do an IVUS and find out what exactly is the picture there.
Another issue. Now, here you are not confident about the size of the distal LAD because of the diffuse disease which is there. Now, in such a situation, when you are planning the case and you know that it is very difficult to interrogate by doing any imaging, like IVUS or OCT in this patient because of the distal diffuse disease, in such a situation, would a CT angiography before taking up the patient for angioplasty help you? Because CT angiography has been shown to help in deciding, in some cases of CTO, about the quality of the vessel in the completely occluded segment. So similarly here, if as a corollary, we could get some idea on the CT angio, would that help you?
So CT will never help you, sir. Basically, CT will give you an idea of where in CTO, in what CT will help you. Actually, it is how the CTO line, maybe it is a tortuous anatomy, we will know what is the lumen size and how it is going. Here, CT will not help you because the lumen only can be identified. What is the vessel size, whether the media to media or the EL to EL cannot be identified. Especially, you cannot do an OCT in this case at all, no doubt about it. Only thing is the choice is an IVUS, where IVUS also I was thinking that till the distal most part, I have to take the IVUS catheter, then only I can understand. I put a 75 millimeter stent up to the distal most, almost up to the distal most LAD, where the tip of the IVUS catheter, if you are pushing, you cannot take up to the distal part.
Okay, we have Dr. Gopal Krishna on the panel there. I think he has joined us. Can we have some comments about this particular case from Dr. Gopal Krishna, please? Dr. Gopal Krishna?
Yes, that's a nice case, Dr. Pratap. Excellently done, and I don't think it can be advocated for everybody, and you have done it and shown the long-term result and benefited the patient. Congratulations. I'm very impressed with the result. My only question is, when you did the to circumflex, did you do a kissing in that time?
Yeah. We did a kissing with a 4.5 balloon into the circumflex, 3.5 balloon into the LAD, and there is a pot done by a 4.5 balloon in the LMCA.
So when you did that kissing, probably there is enough room for your stent in the distal LAD to go. Did you?
No. This is actually done. The final thing, actually, it was done in 3 times. One, the first attempt I have done only distal circumflex. Second attempt I did only the LAD, mid and distal LAD. Third attempt I have done LMCA bifurcation. Okay. And that time my stent is down. I have no problems.
Okay. Congratulations. Nice result.
Points well taken. A very patient approach. A lot of patience to take care of this patient over a period of few months and have a successful result. Otherwise, the knee-jerk reaction is to do as much as possible in the first or the second attempt itself. I congratulate you, Dr. Pratap Kumar, for the excellent planning and execution of this case. We'll move ahead. Can we move ahead with the next speaker to be presented by Dr. Rajaram, OCT follow-up of BVS cases. Dr. Rajaram, please.
Ravi, can you introduce Dr. Rajaram to the audience, please?
So Dr. Rajaram is part of Dr. Kasturi's team. He's been working with Dr. Kasturi, sir.
We are having some problem about sharing the screen. Can somebody help him for sharing the screen, please?
Kiran, can you please guide Dr. Rajaram, sir?
Probably, sir, internet is unstable. Dr. Rajaram, sir, look, sir,
No, we lost him, looks like.
Yeah. Internet is unstable.
He's joining, sir, 2 minutes.
So shall we go to the next talk? We have Dr. Anand, sir, with us. Dr. Anand Gyanraj, sir, is already there with us.
Okay. Dr. Rajaram, we'll come back to you. In the meantime, can we share the screen from Dr. Anand?
Sir, Dr. Rajaram has come down, sir.
Dr. Anand?
Yeah.
Rajaram, sir, has joined back, sir.
Yeah.
Joined back.
Should I start or?
Anand, sir, I think you can start. We'll take Dr. Rajaram, sir, next by the time he sets up. Dr. Anand, sir, we have your screen with us.
All right.
Please go ahead.
Yeah. So this is a patient with post-CABG and...
Can you increase your audio, please? Audio volume.
Can you hear me?
Yeah, now better.
Okay, fine.
Please go ahead.
So this is a patient with a triple vessel CTO, post-CABG, and the only separating vessel was the Lima. 65-year-old male, diabetic, hypertensive, hyperlipidemia, had a CABG in 2006 for triple vessel disease, had a Lima to LAD, SVG to PDA, and OM. Now he presented with class 4 symptoms, PND, orthopnea, wheelchair bound, and severe LV dysfunction. He had angiography few months before, 2 years before that, which showed native triple vessel disease, proximal LAD total, and circumflex, mid-circumflex CTO, and proximal RCA CTO, and occluded SVG grafts. And the Lima to LAD was patent, but there was a distal LAD disease beyond the Lima anastomosis. So they had done a PCI to that through the Lima in 2018, which was patent. So now this is the angiogram of the left system. You can see that circumflex, mid-circumflex is occluded. LAD is totally occluded. And this was the right. Right was also occluded just after the conus. Now, because of the severe LV dysfunction and the current scenario, there were not many options because LAD septals were not seen. So the most likely approach should be antegrade because there was a tight lesion just proximal to the anastomosis of Lima. So going backwards through Lima is also risky. So anyway, decided to go antegrade first. The first wire went through something that looked like probably RCA. Then I quickly realized that that was a branch of the conus. So then we attempted to wire the one track that was just proximal, 1 millimeter proximal to that. And you can see that there was some progress in that. Then coming back to LAO, that wire continued to progress to some extent, but faced a lot of resistance just lower down at the point where the wire is stopped right now. So I changed, initial wire was a Fielder XT. So because of that resistance, I changed to a Gaia 2. You can see that the Gaia 2 made significant progress, but I think it was in some RV branch and it was going away from where it should have been. So I switched to RAO to check, and you can see clearly that the wire is not in the track where it's meant to be. So I changed back to, this was actually Gaia 1, because I was trying to mobilize and get back into the same track, but it still continued to go into the RV branch. So I pulled the wire back and took another angiogram. You can see that the distal RCA was filling from the conus. Though I had bilateral access, I used this for this time. And you can see that the RCA, origin, the point where the wire has deviated is way proximal to where I was. So I rewired it through the current track in the RAO position and was able to get down significantly to the mid portion of RCA. But again, there was no progress. So I took a microcatheter to that point, and for just like that, I took to Fielder XT again. And strangely, the Fielder XT just went through. Probably there was a micro track which the Gaia was selectively not picking. So Fielder XT went through, and I exchanged it with the Grand Slam and tracked the micro Corsair down to distal LED. And this was after some ballooning. You can see that the wire is well in the PDA. Then if you see the previous picture, actually there was, I realized that there is one more branch here. I was not sure whether this is the PDA or this is the PDA, because there were no clear septals from either one of them. So I wired that branch also to make sure that we don't lose it when we stent it. But later I decided to go with the distal most branch rather than the proximal branch, and stented with the Zion's Expedition. This is 2.7538. And then again with another stent, which was 348. And this was the result for the RCA. Then I tried to open the circumflex, which was much easier than I thought. After placing the microcatheter, this was Gaia 2. It went without much difficulty. So I crossed it and ballooned it and kept it there, kept the wire there, because I wanted to finish LAD and then come back. Now, initially it took Whisper, and then the Corsair is parked in the proximal LAD. Now this is a Miracle 6 wire. So because there was enough calcium to guide the wire, I just tried to wire it, and it was a lot easier than I thought. It was quite straightforward. If you can see, the wire passes without much difficulty straight down. So you can see the stent below of the previous PCI, and the Lima anastomosis is just above that stent. And I took the wire into the diagonal, just proximal to the anastomosis. And this is a shot from the Lima also. No, you can see the proximal LAD, few diagonals filling, few septals filling. And now this was after ballooning the proximal LAD with a 1.5 and then 2 millimeter balloon. And this was a shot from the Lima and the proximal LAD. You can see that there is a clear small space. Here, I decided to stop the stenting before the anastomotic point so that the lima flow will be preserved in case there is a future problem with the stents. And we can always cross that small segment if there is a problem with lima. So I decided to park the wire in the diagonal and stent up to the narrowed segment. And this was a 2.5, 28 Zions. And then I took a 2.5, I think this was the 23, stent into the circumflex and parked it there, and then tried to do a mini crush kind of procedure. So I parked the proximal end of the stent just beyond the bifurcation, and then deployed it, which was a good flow. Then took a 3.5 into 28 for the left main to LAD. This was a 3.5 28 from left main to LAD, and then rewired into the circumflex. This is the rewiring into the circumflex again through the struts. Then did a small proximal LAD and a left main dilatation with a 3.5 balloon because I was not able to pass the circumflex balloon at that time. Then managed to pass a 2.512 balloon into the circumflex and did a kissing balloon with the 3.58 and 2.512 balloons. Then did a proximal pot with a 3.75 at 20 atmospheres. And this was the final result. And on day 3, patient was discharged. EF improved from 20 to 34%. Patient was able to walk without symptoms, short distances inside the ward, and his creat was okay. Thank you. So this was a challenging case that was because of the severity of the disease, and patient was with severe LV dysfunction. Those were the main 2 challenges. Thank you.
Excellent presentation, Dr. Anand, especially comparing your case with Dr. Pratap's case, where both the patients have got LV dysfunction, difficult anatomy in both the cases. One patient managed in 3 settings, one patient managed in 1 setting. So there are 2 different ways of managing difficult cases. And it's a good example. And at the end of the day, we have to see to it that the patient is safe. Both the strategies have been successful. So before going ahead with this discussion, may I invite Dr. Gopal Krishna for his comments on this case as well as a comparative analysis of both the cases. Dr. Gopal Krishna, please.
Anand, excellent demonstration. Congratulations, Sridhar. And as Dr. Uday was saying, it was a, I would say with a comment that PCI saves lives. This is because the improvement in the LV function, probably definitely both of you have added a lot of years to their lives, and an excellent case. And hopefully it's not a patient who will be tackled by everybody. Managing 3 CTOs with difficult wiring and difficult sizing of the stents, and hopefully the patient. How much longer follow-up you have for this patient? When did you do this case?
No, this patient was done just a month back, so I don't have follow-up. Yeah. But at discharge, his EF had improved at least 10%. So I think he will come back.
Immediate follow-up has been good. A well-demonstrated management of CTOs by antegrade approach.
Thank you.
So before I go to Dr. VK Shah, may I have some comments from Dr. Pratap, please?
Yeah, sir. Actually, it was Anand done a wonderful case. Basically, in the first attempt itself, I could understand that Anand, I could see a microchannel in the RCA, which definitely, I was not sure about the distal vessel of the circumflex. There are 2 important measures in any CTO intervention. One, you should see the distal vessel. I could not see the distal circumflex. It was whether Anand, you could see the distal circumflex at all? In any shot, I could not see that.
No, there was a small track and there was one OM that was seen. So there was a microchannel.
This is a very important message. Actually, you should see a distal vessel before attempting any vessel. I think as he told, this was an important thing. The lady actually, even when the lady was actually having a flow from the lima, he attempted the LAD CTO, which probably would have helped the septal flow. That is actually the most important thing. I was telling that the septal flow was not getting because proximal to the distal to the septal artery there was a tight disease. That is the importance of opening up that LAD CTO, which people may think that you have a lima to LAD. Why do you open that LAD proximal part? That is very important because the septal flow will be regained after doing the intervention. So I think that was a this was actually a case which I have seen since I am also doing a lot of CTO. So I could see that it is an antegrade approach only possible. There is no retrograde approach possible in this case. It was nicely done by Anand.
Yeah, thank you, Dr. Pratap Kumar. Dr. Vikesha?
I think very well done, Anand. And as per what Uday's comment, I don't think, Pratap's case and Anand's case can be compared to each other, Both had different clinical scenario. Pratap's case was elderly, came in pulmonary edema. He had a CKD, which was around 2.5. And so therefore, according to the clinical presentation, I think the cardiologist has to take a call whether he is going to do all the things at the same time. It also depends upon what is the hospital's policy, what is your current way of doing the practice. Many things are taken. So I think ultimately, whichever way you do it, whether you do it stage procedure, it has to be safe without compromising the kidney functions, without giving more dye, without more exposure and radiation. And our final outcome should be good for long-term use. I think both the cases were done well and both had a different clinical scenario.
So you have to come back to discussion. Dr. Uday.
Uday, where are you? You vanished,
Dr. Pratap sir, you can take the lead before he joins us back.
Yeah, actually, then if there is no more questions, actually, and we can just go, Dr. VK, we can go to the next case.
Presenting me?
We can go to the next presentation if the presenter is ready. We can. Anand, thank you very much. We'll go to the next presentation.
Who is the next presenter?
Yeah, Dr. Rajaram sir, are you able to share your screen?
Yeah,
can you share your screen?
I'm sharing.
Yeah, Rajaram, please.
Okay.
Yeah. No, not correct. Share. Go ahead.
Is it okay, sir?
Sir, can you put it in presentation mode, sir? Yeah.
Yeah. Am I audible?
Yeah, very well. Go ahead.
Thank you. And
so we have Uday back with us.
So good evening, everyone, including the panelists. Sir, today I am going to present two of our follow-up cases of bioresorbable vascular scaffolds, which we have done a few years ago in 2016. So we want to share our experience with these two cases. So first case is the patient of 52 years old, male patient, diabetic hyperlipidemia patient, and presented with a history of chest pain and exertional dyspnea in 6 months. His blood pressure was normal, 130/80. Treadmill test was positive with fair LV systolic function. So,
Dr. Rajaram sir, it seems you have internet unstable, sir.
The angiogram was showing proximal LAD 70 to 80% stenosis and proximal.
Ravi, we'll go to the next talk. I think his internet is not proper.
We can go to Dr. Vikesha, sir. Dr. Rajaram, sir, we'll come back to you. Looks like your internet is unstable, sir.
Yeah.
Okay. So should I share my screen first?
Yeah, Dr. Vikesha.
Yeah. Is it okay?
Sir, not yet shared, sir. Yeah.
Okay, let me bring the PowerPoint here now. Is it visible now?
The slides.
Okay.
So can you put it in presentation
mode? Yeah. Okay.
Yeah.
You're good to go.
Okay, am I audible also now?
Yeah, you're audible.
Okay, fine. So this is a story of a 71-year-old male who presented with history suggestive of unstable angina of recent onset. Risk factors were hypertension and chronic smoker. No other comorbidities. ECG was normal. Stress test was positive for myocardial ischemia. Echo showed normal LV function, and biochemistry was normal except dyslipidemia. So CAG was performed based on these findings, and it showed through the radial artery, which shows left main 50% stenosis before it divides into LAD and circumflex. Bifurcation angle was more than 70 degrees. LAD was type 3 vessel with 80% ostial lesion, progressing, extending into the proximal segment also. Mid and distal LAD were normal. Lesion was 110 by Medina. Circumflex was codominant and normal, and RCA was codominant and normal. So calculated syntax score was 18 in this particular case. Euro score was 1.24. So low syntax score and also low surgical risk. So patient was given the option for going for both. CABG versus PCI. And therefore, what do the guidelines say? As per this, whenever you have a low syntax score, both feasible. CABG as well as PCI are 1A indication. However, we had given the option of both the things to the patient, and ultimately he decided to go for a PCI. This is his angiogram, as you can see. He had a left main 50 to 60% stenosis before it divides into LAD and circumflex. Then there was a LAD ostial 80% stenosis, which was progressing into the proximal segment. Mid and distal LAD were normal. The bifurcation angle was more than 50-60 degrees. So the angioplasty was done through the femoral artery, 7F guiding catheter, 3.5 EBU. Both the LAD and the circumflex wired were two soft wires. One was BMW and one was run through wire. Before I wanted to perform any intravascular imaging, I did a balloon dilatation of this patient. Sorry. The LAD was dilated with 3 by 12 or 15 NC balloon, or 2.5, I don't remember the balloon. So after this balloon dilatation, since the lesion had dilated, then I decided to do the OCT. And this was after the first balloon dilatation, the OCT findings. So as you can see, from distal to proximal segment appears to be normal distally, mid segment appears to be normal. So this OCT showed me what was my morphology. It appeared to be fibrous plaque, more significant in the ostial LAD and distal left main. The size, the diameter of the distal LAD was around 3.25 to 3.3, and the left main diameter was around 4.8 on the OCT in the cross-sectional view. And it also gave me the length of the segment which I need to stent it, which was approximately 21 millimeters. So based on this OCT findings was my strategy of putting a stent which was 3.5 into 26. I think Medtronic Onyx was selected, and we stented the left main to LAD, starting from the ostium of the circumflex, which was adjusted in the LAO 45 cranial view, covering the entire ostium, and the LAD was covered adequately. The stent was deployed at around suboptimal pressure of around 8 to 9 atmospheres, considering that it was a 3.5 stent, and the distal diameter was 3.3. After this balloon after the stent was deployed, the stent was redilated with 3.5 NC to a little higher pressure at the ostium. After the dilatation with the NC balloon, I wanted to do a what in the proximal segment or in the left main, And before this, I noticed that on the angio, the circumflex artery or the ostium was pinched, So I wanted to cross the ostium of the left main of the circumflex, and therefore I decided to do the prot first in the left main before I rewired the circumflex. So this was the pot done with, I think, 4.5. The balloon was kept exactly at the carena, and then the ostium of the left main was also flared with the same balloon. Following this dilatation, this was the image. You can see the circumflex clearly pinched, So we decided to do the OCT at this time, and this was the OCT run which showed us properly deployed stent, no dissection in the distal edge of the stent, well apposed in the proximal LAD, as you can see. And then the circumflex, you can see, on the cross-sectional view, that it was open, but there were struts hanging into the circumflex artery. And that probably gave us an impression that we need to recross the circumflex with another wire, keeping first wire as a landmark. The original wire was removed. And a balloon dilatation with 2.5 by 12 was done across the circumflex ostium to crush the stent towards the carina and the wall, so that the circumflex ostium remains open, which did not appear to be diseased. But should the patient require a further intervention at a future, it will be possible to do it very easily. So this was the post-angio after the balloon dilatation, and a pot was done again, after this. So this was something like side pot. A final OCT was done after this, which showed proper apposition of the stent in the distal LAD. Here you can see the stent in all the three views. So you can see the struts are out of the circumflex now, And the stent is well expanded. So this is the post-OCT bifurcation. You can see after the initial balloon dilatation following the stent implantation, there were struts remaining into the circumflex ostium, And this was dilated with, after doing the pot in the left main with wire recrossing with another balloon of 2.5 by 12. And this was the result when we dilated the circumflex, keeping the ostium fully open. The idea of showing is this was that if you leave these threads like this, hanging into the ostium, following re-endothelialization, this will produce restenosis of the circumflex artery, and it may become difficult to cross the circumflex in future. So this was the area which we achieved after the post PCI. In the left main, it was 13.2, and in the LAD 9 square millimeters. And this was the final angiogram after removing the OCT. As you can see, the struts circumflex appears to be okay. Left main is well dilated. This is the final. Thank you. So this was just to show that circumflex, which is normal and a dominant vessel, if you are doing a provisional stenting, and if the ostium of the circ gets compromised, it is difficult to see on angiogram whether there is a real restenosis or whether it is a strut which are hanging into the circumflex. This is where the role of OCT comes, which helps us to know whether ostium is normal or whether the struts are covering the ostium. And therefore, you need to push the struts outside the ostium so as to facilitate future interventions if required. And this is a technique which I followed was side a port side port. I did not do a kissing balloon dilatation in this patient because I thought circumference was totally normal at the ostium. Thank you.
Yeah, Dr. Vikesha, it's an excellent presentation. And can you come back to your last slide of the OCT where you have shown the pre and the post?
1 minute.
Is it possible for you to do it now?
1 minute.
No, by the time you do that, I just wanted to ask a question. You have done an excellent result where the struts which are overhanging over the ostium of the circumflex after the balloon dilatation of the circumflex artery, you have shown that the struts have gone away towards the wall of the ostium.
Yeah.
Why did you not do a OCT run? We already had a wire OCT run from the circumflex to the left main.
No, but the OCT from the left LAD to left main was so vivid, you know, Uday, that you could see the ostium very, very clear, you know, very, very clear, without any plaque, without any stenosis, you know.
See, I'm not,
and therefore, I did not feel the necessity of doing the circ OCT.
Yeah, no, I'm not saying from that point of view.
Yeah.
Before I invite the other panelists for a discussion, why I asked you that question. There is no doubt that the two struts have now not, they are not across the ostium of the circumflex. It is a successful case. But from academic point of view, not from clinical point of view, from academic point of view, if you take a OCT run from the circumflex into the left main, then you can see those struts are going into the circumflex wall and they are acting as a stent. That strut is acting as a stent on the ostium of the circumflex. So even though the case is excellently done, I'm only asking from an academic point of view for a demonstration. There are no two ways about what you have done. Can I invite a comment from the other panelists, Dr. Gopal Krishna and Dr. Pratap?
Yeah, I mean, the nice point brought out by Dr. Uday. One thing is, if we make sure that you are going to the distal strut of the stent, it obviously debuts both walls and stents the ostium. The only thing is, after the wire is in, you do an angio. What we do with the OCT is, you do the part, then try to wire by angiographically to the distal strut, and then do a OCT. Now you do your optimization, whether the stent is good or not. At the same time, you can also see whether it's wire has gone to the distal strut. If you make sure that the wire has gone to the distal strut, it automatically the stent abuts the wall. The one point in favor of doing an OCT, what I would do is routinely I do what Dr. Shah has done. But if angiographically there is any haziness in the proximal LCX, a doubt, then I would do a LCX to LM run to see the cause of haziness, whether it is a thrombus or a dissection, whether the dissection merits an intervention or not. You want to do a TAP or a provisional getting into two-stent strategy. If the angiographically it looks okay, and there is no haziness or anything in the left circumflex ostium, because I have 3 patients who had haziness, I did what you have said, and I found out they are minor dissections. There is nothing, no study has shown what to do with this kind of dissections in the side branch. We know dissection proximally, distally, where you leave it, where you handle it. But for the side branch dissection, there is no data from the key opinion leaders. So I left all those patients with a minor taking the standard criteria. They're doing okay. So that helps whether you need to fix the osteomal circumflex if there is a major dissection or something. That's an important point. Thanks, Dr. Shah.
Yeah. Well taken. You know, Gopal, actually in the Nordic 3 trial, they have shown that if you have a type A dissection or type 1 dissection in the side branch with a good distal flow, the MACE rate is same when it is followed up for a longer time, whether you have do a procedure or you do not do, you know. So it is better to be left alone if you have a type A dissection with a distal TB flow.
Yeah, it's an excellent demonstration of OCT and the way you have to do a bifurcation lesion. There's no doubt about it. Can I invite some comments from Dr. Sridhar, please? Dr. Sridhar Kasturi.
Yeah, actually, it's a very well demonstrated case, the bifurcation, the crossing the struts and how the struts are opened, everything. But there is no definite data whether what is the fate of this side struts over the side branch. Because routine kissing in provisional stenting is associated with more MACE rate. So the definite kissing is required in two-stent technique, but it's not recommended, but only if they have a timigrade flow is less than 3, or if the patient is having a side branch dissection, or if the pinching is more than significant, more than 70%, or if the FFR is showing any functional significance. But routine kissing, the Nordic study has shown the MACE rate is much more with the provisional stenting. But we are not sure because these side struts or side branch struts also, some of the papers have shown very clearly associated with increased tissue growth that may hamper the flow. So that's the reason if imaging is there, like a side part, that is also one of the best strategy to clear the struts with minimal slightly projecting into the side branch instead of extending more aggressive kissing balloon. I think what he has done is a right job. Dr. V.K. Shah, congrats. He has shown excellent result. Even that a circular opening of the side branch astem is nicely seen. And the one is when we are doing the side branch assessment for IVUS, pullback of the side branch is needed. But OCT, the side branch osteum, you can assess very clearly. And OCT many times with the main branch to a main vessel, if you pull, you can assess the side branch very clearly. So it is not a mandatory in OCT, but in IVUS it's a mandatory.
Yeah, point well taken. Yeah, Pratap, please go ahead.
My opinion is actually whenever you do an imaging like this, when you do, actually he planned to do a balloon side pot. So actually in that case, definitely the imaging from the circumflex is also is the ideal situation to understand. We may not see the osteoproximal part of the circumflex even by OCT. As Sridhar told that you may see everything in that part, but osteoproximal part, you may miss it out. But if you do one more run from there, if you have no problem, it is ideal. But we always do for IVUS, but OCT is a question mark. As Sridhar told, actually it is not mandatory, but can be done.
No, if we are doing side part, compulsory, mandatory, we have to do it. But without side part, provisionally, if you want to assess the side branch, that time you can do. But once you do the kissing, it has to be done.
See, actually, Sridhar, my question is actually to Vikesha also. When you do a side part, is it not required that you should do a kissing balloon inflation after the side part?
No, Pratap. Though there are no randomized trial for that, there is enough bench data now available.
Okay.
That pot side pot is as good as kissing balloon dilatation in selected cases like what we have shown here.
This is recommended
and the COVID study, which has clearly shown, that this side pot is very, very easy, much safer, and avoiding too many steps in the patient.
Second question is actually, what will be the size of the balloon you used for a side pot in this case? You used a
I used a 2.5 balloon because my intention was initially just to separate the strut that was floating in the left in the circumflex without touching the walls of the ostium of the circumflex, so as to create any dissections or anything.
Okay, whenever you see a 3 millimeter vessel, you use a 2.5 or
2.5 balloon. I used a 2.5.
Any data for that?
No, this was my gut feeling. That's all. I don't think there's any data for this.
Recent EBC guidelines have recommended very clearly side pot is recommended, and that is only with a minimal projection. Instead of this is alternative to kissing balloon. Mainly kissing balloon.
What will be the size of the balloon in this case? Size of the balloon? What, Sridhar?
Pardon?
What will be the size of the balloon?
You can take a same size or slightly small, but it should be projected only 2-3 mm.
That is okay.
1:1 ratio.
That should be nearly 4 atmosphere or not, more than 6 atmosphere is not allowed.
Yes. Yeah.
Can I invite a comment from Dr. Ajay, please? He's on the screen.
Yeah. Good evening, Dr. Sridhar, Dr. Pratap.
Yeah, good evening, Ajay.
Couldn't help, such an interesting, nice discussion. So I couldn't help participating. So basically, the side pot has come from the bench studies and some anecdotal studies. There's not yet adequate long-term randomized comparative data for both. But what definitely the bench shows is that the shear stress seems to be a little more favorable with pod, side pod rather than a kissing balloon. In fact, whenever one does a kissing balloon for a single stent strategy, one deforms the main branch stent slightly, and however much they have tried to correct it, even on the bench, it doesn't actually get corrected completely. And that led to the Foyne et al.'s shear stress studies, which have shown that actually the pod side pod, if the side branch is correctly dilated, or as has been spoken, that not more than 3 to 4 millimeters into the side branch, with a slightly smaller balloon so as to decrease the risk of dissection. The size of the balloon is also actually sub judice, to use a legal term, because there's not much evidence there. The reason why people use a 0.25 or a 0.5 millimeter smaller balloon is to decrease the risk of dissection of the side branch, of the proximal side branch. And this is supposed to be done in patients where there is less than 50% disease in the osteo of the side branch. If it is more, many people will leave it alone without touching it, because the risk of causing a dissection in a diseased side branch is worse than the risk of leaving something with slightly decreased flow. And in our own personal experience, in an article which is actually under consideration for publication, we have done nearly 80 LM-LAD crossover, in which we did not touch the side branch. We just measured the FFR into the side branch, and whenever it was more than 0.8, we just left it alone. And at the end of 1 year, we have had just 2 adverse events in the whole trial. But this is very closely dependent on using the correct size pot balloon and on using the correctly sized distal vessel stent. There's not much evidence on this, but this is evolving. And in fact, they have said that it is possible that the pod side pot might have better events, but it's only possible. There's no evidence as hard evidence in comparative randomized controlled trials. Thank you.
Yeah, point well taken, Dr. Swami. This issue is open to debate. We can argue on both the sides. Why I made that comment initially about the OCT run from the circumflex to the left main was because he has very effectively shown that the struts were taken away from the ostium along the wall. And then what happens when you take the struts away from the wall, from the lumen onto the wall, is that these struts, they go project towards the circumflex, and the strut acts as a mini stent. And this was an opportunity. This is an opportunity to demonstrate such a thing, which was very well done. And we could have learned from this. Have they really acted as a stent, or they are not acting as a stent, and we have just taken the carina away? This is an excellently managed case. Either way, we can argue till the cows come home. And excellent case, Dr. VK. Shall we go ahead with the next session?
Yeah. Yeah, we will move on to the next session.
Sir, we have one more talk.
One more case.
Oh, yeah, one more talk. Yeah, Dr. Ravi Kiran.
Dr. Rajaram, sir.
Yeah, please go ahead.
Internet is stable now?
Yes, sir.
Just check once.
Sir, if you have any problem, you can switch the camera off, sir. The internet will be better for you.
Am I audible, sir?
Yes.
Hello?
Yes, you are audible.
Yeah, thank you very much, sir. So my case is, it is a bioresorbable vascular scaffolds which we have done few years ago. So we want to share our experiences. So this is the first case. He is a 52 years old male patient, diabetic hyperlipidemia patient, presented with the chest pain and exertional dyspnea in 6 months. His vitals are stable with a fair LV systolic function, and this is the angio we have done, showing proximal LAD 70 to 80% stenosis, and then proximal RCA 80% stenosis, and mid RCA is around 90% stenosis. So we went ahead to put a biovascular scaffolds in these cases because these vessels are a little bit straight, and then we can easily maneuver the stents. So we have engaged with the XB3 guide, and then we have passed the BMW wire, and then we have pre-dilated with the 3x12 mm NC truck balloon appropriately, and then we took the 3x28 mm Abbott BVS absorb stent. Then we have deployed in the LAD. Then similarly, we have deployed 3x28 mm absorb BVS in the mid RCA, and then in the proximal portion 3.5 to 28 mm absorb BVS was deployed. So this is the final result after putting the stents in both LAD and RCA. So after 4 years, when the patient was in regular follow-up with the dual antiplatelet therapy, so just out of curiosity, we have done the angiogram for this patient. Just to you want to know. To our surprise, these vessels are absolutely normal. There was no restenosis or any kind of this thing. So this is the OCT we have done in this case, just to know what happened to these stent struts and all those things. It is showing the mid RCA. So it is this neoatheroma and this neointima is well circumscribed. These footprints are well embedded. So this is the proximal RCA, and then you are seeing the LAD also we did, and it's nicely opened. So these are the static pictures of the OCT in our study. That the proximal RCA is showing MLA of almost 7.2 mm, and then mid RCA almost the same thing, 7.2 mm MLA, and then distal RCA is also showing around 7 mm. So finally, these are the good results, and we are also seeing this two stents. This is the stent in stent appearance in this left image. So this is the inner stent strut, and this is the outer stent strut. So this is nicely demonstrated in this OCT picture along with the footprints we are seeing. So some of the areas it is also resolved completely in this LAD tracing. You can see in this LAD also, this proximal LAD is having the MLA of 8.3 mm square, and then mid portion of the stent also showing the 7.2 mm, and then distal edge is also showing MLA of 4. So here you can see that completely resorption of the footprints also there. It is completely filled up with the granulation tissue. So there is about the shapes and all those things. You can see there are no any disruption in the stent struts when we have displayed. So this is the final comparison of the previous angiograms. So this is the before angiogram, this is after stenting, and then this is after 4 years, both LAD and RCA. Our second case is he is a 54 years old male patient, diabetic, presented with a chest pain associated with sweating. So in the middle of the night, so it was diagnosed to have the anterior MI within a window period of 4 hours. So we have thrombolized with STK. Next day we did the angiogram. So it was showing the middle AD 90% stenosis. Here you can see clearly. Other vessels are normal. So we have pre-dilated appropriately, and then we have deployed the 3 into 28 mm biovascular stent absorption. So this is after putting the BVS. So results are absolutely good. Then similarly, we have followed this patient after this patient came after 5 years. So you are seeing there are no the footprints in this. This neo intima is absolutely clear, and it is very thick intimal layer you are seeing. So this is the static pictures of the OCT in the LAD territory. The proximal edge it is showing the MLA of 7.2, and then mid one is 4.1 mm, and the distal edge is showing the 3.7 mm. As you can see, the entire vessel itself is a very narrowed vessel we have taken. So this is the before stenting, and this is after. This is the 5 years after. So our observations in these two cases is the BVS overlapping can be safely done with the proper wall opposition in the long lesions, and then multivessel stenting in appropriate lesions is possible with a good long-term outcome, and BVS was used safely in acute STEMI situations. So some small review on the current status of the BVS. Although newer generation does have significantly reduced MACE, in particular repeat revascularization and stent thrombosis, metallic devices continue to have limitations like permanent side branch occlusion, restriction of non-invasive imaging of coronaries with MSCT or MRI, and interference with the ability to place a grafts at the stented site. The development of some late adverse events such as restenosis and stent thrombosis has been attributed to persistent inflammation. So impaired vasomotion, pathological vascular remodeling like ISR and neoatherosclerosis prevents the process of positive vessel remodeling, and the restoration of vascular physiology, late stent fracture, etc., all continue to have an ongoing annual risk. So BVS were developed as a solution to provide temporary vessel scaffolding and local anti-proliferative therapy to prevent neointimal hyperplasia, to restore vasomotion, allow for adaptive shear stress, luminal enlargement, and vessel wall remodeling. Overall, to restore the native vessel anatomy and the physiology, a process termed vascular reparative therapy. and most importantly, improve long-term clinical outcomes after complete resorption compared with the metallic disc. So these are the details of the biovascular stents used with the backbone of PLLA, that is, and also some metallic metals were also used, magnesium and then iron bolts, with the stud thickness of almost ranging from 70 to 150, 160 mm. So they have absorb stent was tried in various clinical trials, both in the simple as well as complex populations, both in the elective cases as well as in the acute situations like acute ACS situations. So these are the various important studies which they have followed up to 1 to 5 years. The latest one is Absorb 4 by J.W. Stone et al. So they have, so in spite of having all those data, so meta-analysis has shown that Absorb BBS trials are having more TLF and then stent thrombosis. The TLF includes death, MI, as well as target lesion revascularization, which is ranging from 2 to 12%, and then the stent thrombosis is almost 2 to 4% in the various trials. So the first generation BVS has not been able to fully match the safety and efficacy set by the contemporary metallic drug-eluting stents. Data from the Absorb series of trials have raised concerns following the finding of increased early and late TLF, that is 9.6 versus 7.2% when compared with the DISC, and then device thrombosis is in BVS is 2.4 versus 0.7% in the DISC. These shortcomings of BVS may be due to factors related to the device itself, the complexity of the underlying lesion, or the implantation technique. The intravascular imaging provides insight into the mechanism of BVS failure and may be useful to minimize the shortcomings. The recent trials in 2019, this Absorb 4 trials done by Greg J.W. Stone. So what he has shown clearly is it is BVS is it was done almost 2,600 persons equally divided between the BVS and then DES. It is a non-inferior 30-day and 1-year rates of target lesion failure and then angina compared with the metallic DES. There was another study, it is ISER Absorb MI trial done by Bayan et al. It was also published in the 2019 recently. It concludes that among patients with acute MI situations, both STEMI as well as NSTEMI, undergoing PCI with BVS was a non-inferior to the test. In segment, permanent diameter stenosis was non-inferior between the treatment groups. So the role of OCT in BVS, briefly, Brown et al. In 2014, they have shown that in spite of having the adequate pre-dilatation by the imaging, the traditional imaging method, after doing the OCT, almost 10% of the cases we require further dilatation. And then in the Ciazio et al. In 2016, he has demonstrated that the OCT pullbacks, almost 50% indicated the 50% of them changed the strategies in the dealing with the lesions. And in the post expansion also, about 31.8% of the lesions still needed additional expansion. And then it also increased the scaffold area and then corrected the malposition in almost 1/3 of the cases in the BVS cases. To conclude, after the initial enthusiasm from the potential benefits of the BVS, the results of clinical trials brought a great disappointment. At present, DES devices remain the first choice in the PCI, regardless the disappointing outcomes from a variety of factors with the new technology, better understanding of the vessel or patient characteristics, procedural techniques, or the device itself may overcome the limitations. In the future, it is highly likely that refined newer generation BVS with optimized implantation strategies and proper intravascular imaging combined with the long-term and effective DAPT regimens may increase the use of BVS. Thank you.
Thank you, Dr. Rajaram, for this comprehensive presentation on BVS. I just want to know the first case which you presented,
yes,
what was the time duration between the BVS implantation and the final reassessment?
First case was only unstable angina, sir.
4 years. No, duration, sir is asking 4 years.
4 years.
4 years. 4 years.
Second one, 5 years.
Yeah, second was 5 years.
Yeah, so if you see between comparing the two cases, in the second case, it is completely absorbed. In
Yes.
the first case, it is, there are still some evidence there,
Yes.
even though the endothelialization is absolutely complete. So why do you think this has happened in the first case?
First case is only 4 years duration, sir. I think probably even in the studies also, the complete resorption of the devices, that means the filling of the footprints with the granulation tissue, almost it takes up to 4 years in other studies also. So in our cases also, there are certain partial indications that some of the struts are filled by the granulation tissue, and these are all partially disappearing and then collapsing. But still we are able to see the two layers of the struts which we have done in the RCA particularly.
And so long as it is endothelialized and
Yes.
the lumen is well maintained, it would not make a major difference.
Yes, yes.
Sometimes it takes 5 years to completely disappear from the vessel wall, because the so-called golden tube appearance, in those days they were using the term golden tube appearance on OCT. For total disappearance of the biovascular scaffold starts, it may take 5 years. In some patients, it may be 4 years, but in majority of the patients, it took 5 years.
Yeah, point well taken, especially because now I think within few months we'll be having our Indian bioabsorbable scaffold available. We will have to see again what is going to be the result of that. Probably some lesser thickness of the struts. We don't know. We'll have to wait for it, and another couple of years at least for the results to be out. Dr. Pratap? I think Dr. Pratap is not there.
No, sir, I'm there, sir. Basically, I just wanted to tell one point actually, why he used 2 years of dual antiplatelet, 4 years dual antiplatelet, still to be used like that?
No, we have not used dual antiplatelet for 4 years. Only 1 year we have used. Okay. After that, we were following with the high intensity statins, basically. Almost 80 mg of atorvastatin, and then they are followed on the ecosprin, as well as in one patient we were following with the ecosprin. In another patient, we are following with the clopidogrel.
Okay. You are using only single antiplatelet.
Single antiplatelet, along with high dose statins.
Okay.
Dr. Gopal Krishna, please. I think they have left. Any other comments, questions from the panelist?
I think we'll move on to the next session.
Please.
So our next session is image-guided complex PCA in ACS. So now the expert panel members are Dr. Surya Prakash, Dr. Pratap Kumar, Dr. R.K. Jain, moderator, Dr. G. Ramesh. Dr. Uday Kanolkar, sir, you can be the expert panel. Just stay with us. And Dr. Ajay, you are the first presenter, I think.
All right, sir. No problem.
Hello, Dr. Ajay.
Hello, Dr. Ramesh. Good evening.
Yeah, so this
Dr.
is
Pratap,
image-guided
good evening.
image-guided PCA and acute coronary syndrome. We have two speakers. Dr. Sridhar Kasturi, I think he would be presenting the other case. First case is by you. So, anyway, so this is a very interesting topic. So most of the image-guided PCA in acute coronary syndrome probably would be a OCT. I just wanted to see what is the role of FFR, and I was also in these cases. Anyway, I would request Dr. Ajay to start his case presentation. The first case presentation is by Dr. Ajay Swami. So the topic is plaque rupture and erosion in STEMI. That's his topic.
Right, sir. My screen is visible.
Yes, yes.
And before I begin, my salutations to my teachers, some of whom I see in the audience and some who are not here. And my thanks to Dr. Sridhar for giving this opportunity. My brief today is to speak on plaque rupture and plaque erosion, but we will see if we can not make a little more broad-based talk out of it. This is a young male, if you call 55 young, we are all young according to this, with an ST elevation inferior wall MI, elevation 3 more than 2 and a depression in 1 in AVL. So suggestive of an RCA infarction. So he was taken for a primary angioplasty, and this is what it showed. This was actually started by a colleague and then finished by us later. So this is what he did, and he saw that there was a little thrombus in the distal RCA, and assuming that that is the place where there is stenosis, he has stented in the distal RCA. The first stent was placed distally where he felt that that was the place where the flow was the minimum. And but the patient, even after the stent, continued to have chest pain and ST elevation. And then we were called in and we decided to perform an OCT to actually define the problem. And this is what we did. This is the OCT after he has placed the distal stent. The flow is good, but still you can see that the whole RCA is diseased right up to the proximal segment. And the OCT showed us some very, very revealing pictures. If we have time, I'll allow the whole OCT to run. And you can see on the left-hand side of the screen, that is, it is a co-registered OCT. You can see as it comes back that there is a little bit of, we'll just allow it to play, a little bit of calcium and then some fibrofatty plaque, with one narrowing here, and thereafter a little bit of a normal segment with quite a large normal segment of about 2 to 3 millimeters or so. Some more fibrofatty plaque with some little bit of calcium here. And as we come proximally, it becomes a little more interesting. And you will see, if you had noticed in the angiogram, the place where there was gross irregularity. I will try and stop it here. You can see this huge rupture here, this massive rupture here with the intimal disruption and a little bit of overlying thrombus. And thereafter, we come back to the proximal RCA. So what it did show us is that sometimes thrombus may, or the plaque may rupture at one place and the thrombus may go and sit somewhere else, and we go and stent the segment where the thrombus is and then actually miss out on the main lesion. This is what the same thing is on a slightly different, on a still image. And you can see the MLA of 1.32 where it was narrowest. We can see some calcium, and this is where the plaque has ruptured in the proximal segment. That is what, these are the two images there. So finally, the entire segment had to be covered with another long stent, and that's what we ended up with. And this is the post-stent OCT showing us an absolutely well-expanded stent with absolutely no, no residual lesion anywhere, although we had to stent the whole RCA. Probably if we had done a thrombosuction and then done an OCT prior to the first stent, we might not have had to stent the distal RCA. That is what I felt. But then now that that was done, we had to cover the whole RCA, and that's what we got. Now, this is our final angiogram after the post-dilatation. There was a small segment of underexpanded stent, which was then post-dilated. And it looks very nice, but we'll have to follow up this patient and see. This was just done 3 days back. This is another patient, an inferior valve MI RCA pre-PCI. And this actually shows us that erosion and rupture can often coexist. So you can see it's not like it is a all or none phenomenon. The patient either has erosion or has rupture. So you will see that as we come proximally, you can see erosion in one part. You can see calcium, small specks of calcium. This is where the erosion is with the overlying thrombus, and then a plaque rupture, which will come up somewhere here. I don't know if my arrow is visible there. That is the rupture with overlying thrombus. And a good amount of lipid cap. You can see that the attenuation is extremely high. This is highly lipid rich cap, and some flakes of calcium as well. So although we try to say that this patient has plaque erosion, this patient has plaque rupture, this patient has a calcified nodule, in a given patient, you can have all three pathologies occurring simultaneously. Unfortunately, the ACS, it has not read the book. So it kind of comes with all kinds of combinations. And the OCT is an invaluable tool to help us to decide what kind of strategy to use. The problem is the practical considerations ensure that we cannot use it in all patients. And here you can see the white thrombus overlying the plaque rupture. This is what it's like. You can see the plaque rupture here and the plaque erosion with the red thrombus. This is a calcified nodule, the thrombus inside, lots of fibrofatty plaque, another segment of plaque rupture, and white thrombus inside. This is a left main to LAD. Patient came with an anterior wall MI. And we actually couldn't make out too much until we put in the OCT and saw a thrombus overlying a plaque rupture. And we felt that it was proximal and extremely angry, highly lipid laden. So we did an LM-LAD crossover stent. This patient is now nearly 9 months post-procedure and doing absolutely fine. He had a TCFA with a calcified nodule in AMI coexisting. And this was done with a single stent strategy from the LM to the LAD. And this again shows the same thing, that there is a huge calcified plaque here with a dissection that is caused by our balloon, fibrous plaque distally, and white thrombus with almost concentric calcium and overlying thrombus in this patient. And this is what happened after the stent with absolutely good MLAs across everywhere. Now, what about evidence in this particular subset? We are all very fond of using these tools in acute MI, but it's actually not as widespread as we think. The first set of evidence came in 2016 when OCT showed that OCT guided primary PCI for STEMI was associated with a larger final instant luminal lumen diameter. And in another guidance using stent implantation in a randomized multi-center trial, safety of OCT guidance was shown during primary PCI. And this optimized the stent deployment in 1/3 of patients in this clinical scenario, reduced the in-segment area at 9 months of follow-up. But whether such improvements in these figures will have a positive impact on clinical outcomes, we are not sure. What about the prevalence of OCT? In Japan, where they use 25 to 28, 30% of patients with acute MI actually undergo some form of imaging. The total number of acute MIs who actually undergo imaging is only about 4.7%. Although this has been growing, the total number still remains about 30%. But it is a sobering figure that in a country where OCT penetration is throughout the country, only 4.7% of acute MIs actually undergo OCT guided acute MIs. The open label Corial registry, which was in 20 sites looking at 11,731 STEMIs. Out of all these, only 277 were done with OCT guidance. But it did show that there was a reduced all-cause mortality with OCT, 1.9% versus 7% with unguided, and with IVUS as well, 4.9% versus 7%. Although the numbers are small, remember only say 275, 277 patients out of 11,000 odd patients. Other questions with OCT can answer is non-culprit vessels. A sub-study of total and culprit trials has shown that the morphology of the lesion in the non-culprit vessels appears to be at least as strong, if not stronger, predictor of long-term outcome than the non-culprit FFR, which the Americans are so fond of. OCT in unclear anatomy is a clear winner in patients with CAD, IMH, and nodules. We use, in our experience, OCTs to optimize the stent. We don't use it immediately. We use it about 3 to 7 days later in stable patients. We've done about 24 cases, and 6 out of these, 25% required some additional intervention with significant malapposition, under expansion, and edge dissection, and plaque prolapse, which seems to be one thing which is not at all uncommon. We're not really sure about how to manage this, and we're learning as we go along. I'll just show you one example. This is a 62-year-old dyslipidemic hypertensive on first day of MI within 24 hours, but ongoing pain. And he was taken and he had a subtotal occlusion of the proximal LAD. So we quickly first sorted this out, protecting the diagonal, putting a stent in, and then doing a post dilatation, which this looks perfectly acceptable and reasonable in the acute stage. And then we brought him back to the table. As you can see, this is also a recent phenomenon. Is that all on follow-up? We always do an OCT to LAD plus a functional assessment of the OM, because the OM, as we saw, had some significant disease here. So this was our first angiogram at the follow-up. And we went ahead and did first the FFR and the RFR to the OM, which was actually insignificant, so that was fine. And then we did the RFR to the LAD, and to our surprise, the RFR was 0.89, although this doesn't look so bad angiographically, and we confirmed it on a pullback as well. So then we thought we'll do an OCT. And when we did the OCT, if you just focus on what it does show us, although angiographically it looked absolutely fine, you can see a little bit of lipid coming up, say 11 o'clock, 12 o'clock. And there is a dissection which is almost medial and which up to just beyond the distal edge of the stent. And this is something that we had missed on the angiogram. One can see this on the, I'll just play it again. You can see it's a co-registered, this one, and you can see the dissection which is extending to about 5 millimeters beyond this stent until we get to the edge of the stent. And so we went ahead and fixed this particular circumferential dissection here. And this was our landing zone measurement, which we got a mean diameter of about 2.5 or so. And that's what we did. We put in a small 2.5, 12 millimeter stent since we had a clear landing zone, and then repeated the RFR. And this time it was 0.97 and a pullback was done. And we did an FFR after this, and that was 0.92 in the LAD. But we hadn't done an FFR earlier. We just used the RFR, 0.89 to 0.97 it went. And this is the OCT after the second stent has been done. And this shows a perfectly good result and excellent expansion when we broke it up into 2 segments. This is a well-opposed and expanded stent with a plaque prolapse at the location of the post-dilatation balloon. As I said, this is a very, very common phenomenon, and we are still not sure about what to do about this. One thing definitely not to do is try and balloon it, because it only gets worse. And this is our final angiographic result. This is what I wanted to show, and thank you very much for your attention. This is what plaque prolapse and plaque erosion is. But there is a world of physiology and imaging beyond just these 2 figures. Thank you for your attention.
Yeah, Dr. Ajay. I felt the second regarding that we could sense there was some dissection in this thing in the angiographic pictures also, because though OCT was good, you could do an OCT, but I felt the angiographic result was not very good in whatever we could see in this. Just a casual comment. My questions are a couple of questions. How many percentage of cases, you have no financial issues as such, so how many percentage of cases you would use OCT for in ACS? Second question is, did the OCT change your strategy for thrombus suction or using the thrombus this thing in your patient? So any other modality which you could use? And did it guide to change the management strategy for thrombus?
So that's why I prefaced my talk with, that even in Japan, they use only 4% OCT. We are not really using OCT much in the acute situation unless we are in great trouble and we don't know what to do, like in that RCA, in which he had put the stent distally, and I felt that proximally also we need to fix it. We just wanted to be sure, because physiology in acute, MI is not the best answer. It doesn't give you a great answer. Imaging will sometimes help you. So what we normally do is we fix the acute event, fix the problem, and then bring the patient back at between the 4th to the 7th day, assuming that he remains stable. And that is what I showed you, that out of the 24 patients that we have in our series, 6 of them we had to go back in and do something more. I just showed you one example in which we had to put another stent distally. And I must congratulate you for having OCT in your eyes itself, so you can see the dissection without... but you're absolutely right. There was some haziness at the distal edge. Yeah, absolutely right. There was some haziness at the disc. Yeah, there was some haziness at the distal edge, and we have learned that that haziness usually means a dissection at the distal edge. So we are also a little more worried about such patients, and we almost always bring them back and image just to be sure. Sometimes you have a little bit of... to be sure, we are, to be honest, we are not so happy about using so much of contrast in the acute situation. We are learning about saline OCT. It works very well for the RCA, but for the LAD, we don't get very great images. So we're not yet there. Once we perfect that, then we will share on some platform, because I feel thrombus is seen. Thrombus is very well seen. The problem is you don't get good clearance with saline. So you're not able to.
How did OCT guide you? Do you have any cases where the thrombus management was guided, where you could just get off with a balloon without using a thrombosection, or did the OCT guide you in using some other modality?
So if we had to use OCT in acute MI, we would actually have to do it after the thrombosuction. The thrombus guidance, I think, is very is limited, because you need complete clearance of contrast for interpretable images, and the thrombus hides what is there in the.
Moreover, Ajay, if you are actually putting in a thrombus milieu, when you put a OCT catheter, you are actually migrating thrombus distally, and you will create...
Absolutely.
Yeah, one thing I don't understand, that 25% of your cases where you did an OCT in acute MI situation, you had a re-intervention or some other extra intervention was required. But in 7th day or 6th day, if you call the patient for an OCT, I don't think in our practice it is possible for us, Ajay.
Quite so. It is more of a learning for us. I understand. In fact, our own ethical committee, they created so much of issues for us for the second this one. So it has been approved only as a registry. We're not able to randomize because they did not agree. And our consent and all is a little bit of an issue. So we may have done about 45, 50, but only 24 actually we were able to convince to bring them back to the table. And I don't think it is unreasonable. It's all right for us to learn, but our patient is the most important determinant at the center of all this. So I'm really not sure, because even I am not comfortable. We are very comfortable using OCT in every situation, but acute MI, contrast limits, instability of patients, the fear of pushing thrombus with a powerful injection, all these things are very, very strong, negative modifiers as far as the use of OCT is concerned. And getting good images is one thing, but our patient safety is our first priority. So we go ahead with this.
Erosion trial, they used the OCT in all cases, and they proved that most of the cases they did not require a stent in those cases.
That is correct. In patients in whom one can get out the thrombus completely, and you have good flows. And but such patients, out of 10 patients, and our patients don't come to us within the first 2 to 3 hours of their MI. They'll all come 6, 8 hours, 7 hours later, where the thrombus burden is quite a bit. Even after you have removed all the thrombus, up to, I can't give you a percentage, but in some patients, you will still not be able to make out there is a erosion or a rupture, because the thrombus is sitting on top of the lesion and you can't see exactly what has happened. And there's a little lack of evidence and clarity in this particular area. We are just trying to...
In a tense mood in acute MI situation, you are actually saving somebody's life, and you cannot play with that time.
Precisely, sir. So that's what I showed. In Japan, where they're using for everybody, only 4% of patients they're using in acute MI OCT. I think that's a reasonable figure. You know, when you don't know what is happening, or you are sure that you're not going to harm the patient, these are the two situations where I suppose one can use an OCT, and that's not always the case.
Non-culprit vessel, as you said, would be again a good idea some other time.
It's actually both total and that culprit both showed that non-culprit vessel, the morphology of the plaque in the non-culprit vessel seems to be a stronger predictor of the occurrence of ACS in the first 3 to 6 months following this particular MI than even physiology. I mean, I think that means two things. That means that physiology in the acute situation is not so well interpretable. And it also means that morphology, I mean, events tend to cluster around particular times when there's a flow inflammatory state in the body. And the risk was almost 4.5 or 4.8% in 6 months, which is a huge number. I mean, that for every 100 patients, if you have an MI, if 4 to 6% are going to have an MI in another territory, you know, within 6 months, and that can be predicted by OCT, then it is something that we really need to think about.
Any other comment, Dr. Uday, sir?
No, no specific comments. My only issue was in that case where he showed a distal edge dissection on the OCT 3-4 days after the procedure. Do you think there is, looking at the dissection, it is not compromising the lumen much? So do you think there is a absolutely good correlation in this particular case between FFR and OCT?
Well, sir, the advantage of using physiology of RFR was that it was definitely producing flow limitation. Now, the flow limitation was documented by a pressure measurement, and the morphology of the lesion was documented by the OCT. By both modalities, there was an indication to cover or to stabilize this. Now, if the problem would have been if the RFR was say 0.94 or 0.93 and we had a small dissection, then we could have been justified in leaving it. The reason why I brought the case here is to show that when there is a flow limitation, in that case, there is no doubt we have got to cover it. So the morphology and the length were given to us by the OCT, but whether we needed to do it or not was definitely confirmed by the RFR. If one had only a small dissection which was less than 3 millimeters in size, which was less than 60 degrees, and which was not up to the media, we could still have left it, although distal dissections are very dangerous to leave and they kind of cause sometimes some problems. Proximal dissections are less harmful and more forgiving. So I think both modalities came to the same conclusion. So it was an easy decision to make in that particular case.
Okay, fine.
Dr. Sridhar, any comments, or do you want to go to the next case, next presentation? Dr. Sridhar.
I think he's ready with his talk.
Okay, we'll move to his talk. Dr. Sridhar, you can proceed with your talk.
Sridhar, sir, we can't hear you.
Sir, you are muted.
Can you unmute, sir?
Sridhar, sir, please switch on the video, sir.
Now able to hear?
Yes.
Able to hear now?
We can hear you. We can hear you.
Now I'll be showing because standby because Dr. Kaparthi has some other work. He's stuck with some emergency. So I'll be showing on some of the cases.
Yes, just a question. Is there any OCT criteria for thrombus in this thing, ACS, Dr. Sridhar?
Pardon?
Is there some criteria for it, or is there any OCT criteria for thrombus assessment or something like that in ACS?
OCT, one of the advantages, so you can quantify the thrombus, but only thing is really luminal compromise there, good flow is there, like a block rupture is there as per the OCT criteria. Definitely it has to be covered with the DAS, but erosion where the most of the intact endothelium is there, in such cases no need to do it. And if ACS, you have to see, is it because of the block rupture, which is seen in 45 to 50% of the patients, erosion seen in 15 to 20% of the patients, and about 7 to 8% of the patients of STEMI is due to calcific nodule. Remaining are unclassified, like it may be because of the embolism, or it because of the coronary spargem bridging, or it may be because of the even type 2 infarcts, or it may be because of the SCAD. So these are the various presentations, but the majority of the cases, 45 to 50% of the cases are due to block rupture. So block rupture definitely because the large lipid core, suddenly it ruptures with a necrotic core. So these block rupture should be covered with the DAS. That is recommended. But erosion you can manage because most of the endothelium is intact, and you can manage with antithrombotics. But if the SCAD is there, if the flow is good, no symptoms of ACS or ongoing pain is there, still you can manage conservatively. Good TIMI grade 3 flow is there. So like a embolism is there, again you can treat with antithrombotics. And type 2 infarcts primarily target the underlying situation. So basically coronary spasm is there. Those things you have to rule out, and you have to treat accordingly. OCT helps in like a old age patients, particularly like a more than 70-year-old CRF diabetic patients. We see many times STEMI with the calcified lesions where balloon itself cannot cross. So these are all like calcified lesions. In such cases, definitely, even though the patient is having a STEMI, sometimes a balloon uncrossable lesions require the rotablation. So, and the another importance in OCT during STEMI patients, if the plaque rupture is there, large lipid pool is there, more likely these patients are going to have a slow flow, no flow, because the studies have shown the necrotic, the debris will go and fill the distal bed, and that lead to slow flow, no flow. So that is the reason when you see the plaque rupture with a large lipid core and the large lipid plaque, with a thin cap fibroatheромata, more likely these patients, you have to prepare. Always keep the glycoprotein 2B3 by standby. And you see that Nipro is there. All these drugs are there. You have to think about the slow flow, no flow phenomenon. The slow flow, no flow phenomena, less likely if the calcific nodule is there, if the patient is having erosion, but more common with block ruptures, particularly large. And one patient
sir. Before we proceed, we'll take comments from Dr. R.K. Jain sir also.
Yeah, R.K. Jain,
yes, sir.
Hi.
Yes, sir is there. Hello, sir.
Hi. So,
yeah, how are you?
Nice case. I think we should go ahead with.
You can comment something, Jain.
Yeah. No. That Uday Kanolkar said even that Ajay Swami's case about the distal dissection, but he proved himself. Many of those cases, what we learned, many of the dissections we have seen, they're not flow limiting. We leave them alone. But as Ajay Swami can afford all these high-tech gadgets, he can bring them back and do all these things. But in a private practice, it's not easy to do all those things. And many of the times we have left these patients, and we did a follow-up of these patients, and they do extremely well. Because there are two things. Whenever there's a distal dissection, generally they do very well. It's a proximal dissection, the stent, they don't do well. So I know Ajay Swami has proved beyond a doubt scientifically. He proved that RFR is not good. I can't comment. I just can't tell anything. But I don't know for the juniors who is there. Most of the time, you should not worry. Distal dissection can happen because some overinflation. So just leave them alone, and they do extremely well. Because in a private practice and put another stand, the cost, the complications are huge. So I feel scientifically did extremely well, but practically where the resources and all these things, if it's non-flow limiting, TIMI 3 flow, just wait for 5 to 10 minutes. If it's a distal dissection to the stand, leave them alone. That's what I would do rather than put a stent again.
Dr. Jain, I would beg to differ. If the dissection has the criteria which Dr. Ajay Swami has mentioned, if you are fulfilling those criteria on OCT, I may not do an FFR because of cost restriction, but if you have documented the dissection to be significant from OCT criteria, I would definitely stent it. It may be distal or proximal. Now, FFR along with OCT, yes, that can be argued, but I wouldn't leave a dissection distal or proximal to the stent, especially when it is fulfilling the OCT criteria for future problems.
Yeah, but I'm not telling OCT criteria. I told distal dissection, like how Ramesh said, Ajay Swami commented that you have golden eyes. Okay, but I also felt when that angio was played that there's some distal haziness, and there was a dissection. Yes, I'll leave this patient. I will not attend because he is a part of a study or a research grant. He brought him back and he did FFR and OCT, but I will just leave him alone at that point. I'll not bring him back. And if he's a part of a study, okay, I'll bring him back. Otherwise, I'll not bring him. I'll leave with the dissection alone. That's what my say. But okay, if you now tell, if you do an AOCT and see that, I don't know. I don't have experience of bringing them back and doing OCT at that time. What my experience till now, I have at least more than dozen cases, distal dissection, visible, leave them alone. They're doing extremely well. They didn't come back and they are under my follow-up. They are still surviving, all of them. So I don't know, I might be wrong, but distal dissection, non-flow limiting, they do extremely well because it's already tackled. It's not going to progress. The proximal dissection, it can progress, it can attract a thrombus and it can lose. That's what my way of treating. I might be wrong, but that's how I've been training and treating my patients.
Actually, so the Illumin criteria of the dissection is exactly the opposite. I mean, nobody can argue with your experience, but you know, the Illumin and the data is actually opposite. It is the distal dissections which are more dangerous. The proximal one, since there is a stent, it doesn't extend distally. There is a distal dissection. If it is significant, the reason why those OCT criteria have been evolved is that only, that lesions which fulfill this criteria, that they are longer than 3 millimeters, they're longer than 60 degrees, they extend up to the intima. These are the ones which actually progress and cause problems. That is why those criteria have come. And it's again between the two.
That is
these
OCT.
So, correct.
What I am telling, I will not do
No,
OCT.
I understand.
Yeah.
That's what I said. We can't argue on this because there is no angiographic criteria.
I know. We'll proceed to Dr. Sridhar's talk and then continue the discussion.
Yeah. It's a nice discussion. It's a very nice case. In fact, it's an eye opener, and probably next dissection I might do a OCT and then decide.
Dr. Sridhar, you can start your case for this.
Able to see?
Yes.
Able to see? My
Yeah, we are able to see. We are able to see.
I'll be showing some cases how the OCT useful in the assessment of trifurcation and or bifurcation PCA. So when you use the imaging, mainly when you are assessing the left main, this is mainly to understand the severity and morphology of the disease. And once you implant the stent, mainly to optimize the test results. So always assess the luminal area along the length of the left main, assess the luminal area, mean luminal area, plaque burden at the site of the left main, calcification is there or not, what type of plaque, if the calcification is there, needs plaque modification, is it diffuse or focal, and additional parameters in the setting of distal left main, always assess the proximal LAD and proximal left circumflex, assess the luminal area, plaque burden, and any calcification estimating into LAD or LCH. Suppose if you are doing a plaque modification, whether you requires the plaque modification, that is rota from LMCA to L6 or LMCA to LAD. So when you are doing the imaging, whether IVS or OCT, always that is angiographic haziness. Sometimes angiographically, you may not distinguish whether it's calcium or thrombus or dissection. Sometimes it's very difficult. Small calcified nodule is there. Then it may look like a haziness, and it is difficult to differentiate thrombus from dissection. And also a very severely calcified needs rotablation, and it is also useful in choosing the right plaque modification strategy. Luminal vessel wall, as well as always depending upon the severity of the lesion, landing zones, you can see proximally what is the landing zone, distally what is the landing zone, choose the diameter, length of the stent and diameter of the stent you can choose. And depending upon the left circumflex ostium is involved or not, if the plaque burden is less than 50%, L6 ostium is not significantly involved, then you can think of the patient requires proximal stenting or dedicated two-stent technique. And at the same time, severity, the disease block button also very important. Is it more than 50%? That is a LAD or LCX and LMCA. Based upon that, you can choose whether two-stent or proximal stent technique. You are all very familiar. A non-dominant circumflex, if the angle is more than 60 degrees, or lesion in the ostial L6 extending less than 5 mm, less than 2.5 mm, no significant ostial LCX disease by IVUS. IVUS MLA is more than 4 square mm, block button less than 50%. So in such cases, go for proximal stenting. If otherwise, you can go with the two-stent technique. When you are taking the parameters with the OCT, compared to IVUS, the OCT parameters are 10 to 15% smaller. So assume that 4.5 square mm you are taking as a left main criteria. It may be 4 with the OCT. This is sometimes when you are not using FFR, if you have a borderline lesion or diffuse lesion of the left main, you can take the criteria that is for Indians, like Asian countries, South Asian and Asian countries, the criteria is at least the 4.5 square mm above. Then you do the LMCA stenting without any FFR between 4.5 to 6 square mm. You can use the FFR to see the severity of the left main. If FFR positive, go with LM stenting. If more than 7, if more than 0.8, no need. Suppose more than 6, you can defer the procedure. This is recent ESC guidelines. So I will show some cases. This is a 58-year-old male, known case of hypertensive and diabetic, presented with anterval MI. Window period half an hour. And he was treated with the tenecteplase, post-infarct angina, shifted from a very nearby nursing home. And this is the angiogram. You can see the LAD, a very, very tight, long segment lesion. There is a ramus region is there. Ramus also significantly diseased. So this is LCX lesion, and left main appears to be normal. So you can see very critical long segment lesion of the LAD, ST elevation MI, anterior wall, window period half an hour. And then we wide LAD and LCX, right radial approach, 6 French XB 3.5. And this is a 2 pre-dilatations. We did pre-dilatations because the flow is good, antegrade flow is fine. Then thrombolytic therapy started, post-thrombolytic therapy. Then we did acquire the OCT initially because the block burden is more that we were not getting adequate use, but still we are able to see the tri-layer structure. And you can see the ramus ostium, you can see very clearly. LAD is ostium, you can see very, very significant disease. See diffused long segment lesion from LAD ostium. This is the assessment. You can see very clearly involvement of the ramus also very significantly disease, long segment lesion. And this is the assessment. You can see the LCX ostium is fine. It's looking fine. LAD and this, and you can see the LMC is also looking fine. Then we did LAD stenting 2.75 to 40 mm. And this is post-stenting angio. Then ramus also dilated. Then ramus stenting, because LMCA was looking normal, we thought of putting B stent, that is LAD and ramus. If some block button is there in the LMCA, I would have extended into this one. And our intention is to avoid the LCX. So this is assessment after stenting. You can see LCX ostium, ramus ostium, left main, very, very clearly trifurcation. You can see very, very clearly here. And if you see the here, LAD, sorry, you can see the ramus ostium, you can see LAD ostium, you can see, you can assess very clearly what are the area also you can see very clearly. And LAD ostium, you can see maloposition. LAD ostium, LCX you can see, but LAD ostium, there is a maloposition. It's underexpanded stent. So then we took the balloon, you can see very clearly it's a underexpanded stent. Then we took the bigger balloon and upsized it and subsequently expanded very well. Then we got the area of MLA area of 7.1 LAD ostium. This is the final result. Then another 61-year-old male, non-hypertensive diabetic present with chest pain, underwent PCI of RC in 2015, NSTEMI of Antiball, and angiogram showed distal left main, mild lesion, LAD ostial to mid, long segment lesion, ramus pacmal. You can see here, RC is absolutely fine. But if you see the LAD, LMCA, there is a mild lesion distally, LAD ostial to mid long segment, there is 80% lesion. D1 also proximal, almost it's looking like a dual LAD. Proximal 80% lesion. I'm unable to see the origin here very clearly. You can see the LAD, it's almost looking like a dual LAD, very big diagonal, almost running parallelly. But I'm unable to see the origins very clearly. Now you are seeing here LAD ostium, diagonal ostium. So in this case, we wanted to see the OCT. Then right femoral root, 6 French, Chien blue, LAD wide with Chien blue, D1 wide with. This is the pre-procedure assessment of the OCT. You can see a left main, here proximal portion of the left main 13.3, but distal left main 5.6 square mm. There is significant plaque burden here, and just before bifurcation, the left main area is 8 square mm, but here it's about 5.6 square mm, and LAD, you can see 6.7 square mm, but after diagonal origin, very, very critical, 1 square mm, 2.5 mm. So very, very critical narrowing of the LAD. And this is the assessment. Then we wanted to go ahead with the DK crush stenting. D1 was stented with 2.5 to 22 mm stent and crush. D1 crushing. Then we wanted to see the evaluation of the crushing. That crushing, is it adequate or not? What the length of the crushing? Everything we can assess very clearly. You can see the crushed portion of the stent inside the LAD is about 3 mm. This is extended just up to the L6 origin. You can see from here to here, we extended from L diagonal up to the L6, but it did not cross the L6. So the crushed portion just ended it at the L6 origin. So left main, you can see very clearly crushed portion of the stents, multiple layers of the crush. So adequate crushing is there or not. Then D1 recrossed with the two studs were opened with a 2 mm Tazuna balloon. This is the first kissing using 2.5 balloon and the D1 and 3 mm into 12 mm in the diagonal. Then we did LMCA to LAD stenting using 3 into 38 mm stent. Then dot, then final kissing, that is 2.5 NC into diagonal and 3.5 NC. You can see very clearly. Now you can see very clearly stent is here 6.4, 6.8, 5.6, 5.6. Here you can see this distally, the left main, you got the 13.2 square mm and distal left main 10 square mm, 13 square mm. You can see nicely, here you can see the crushed segment very clearly. This is the final result. So whenever you do the OCT, always assess the left main and LAD LCX, and with the stent expansion, the L6 ostium and portion, any like entire L6 stent should be expanded more than 90% compared to the reference diameter. At least you should achieve 80% compared to the distal reference diameter. Similarly, diagonal also compared to distal reference diameter, you should achieve at least 80%. If you achieve less than 70%, that is under expansion. Here, so the figure like a 8, you can 8, 7, 6, 5 also another way, but always if the vessel is too big, don't stick to that criteria. See that at least you are achieving 90% of the reference diameters, and always see the stent is adequately expanded or not. The stent studs also you can assess while crossing also whether you are crossing through the proximal stud or distal stud you can see before crossing with the balloon. This is like a optimal crossing. You scroll back and see whether you are crossing proximally or distally And based upon that, whether it's DK crush or T-stenting or mini crush, based upon that, you can choose the where to cross. Is it a mid-strut or proximal strut or distal strut? Take the OCT imaging. And once you are satisfied, then only the another one is you have to cross the link free, whether it's proximal or distal. There is a study from Japan. If you cross the link free struts, then expansion will be much better. And this is how the distal crossing, there you can scroll back and see that part is not extended, while the part belly is not extended up the carina, and part should be done before crossing into the side branch. This is to see whether you have crossed it through the proximal strut or distal strut. The struts are through, just now we have discussed whether it's part, or side, or like a kissing balloon with a minimal inflations, that is also works well. This is when you are doing the DK crush. Initially, the stent, side branch stent, crush it, again cross distally. This is the October criteria. And there you can cross it and first kissing. Again, you can do the MB stenting. Once you do the MB stenting, do the pot. After pot, again cross it. Then side branch wiring. Again, you can do the kissing. This is a crush evaluation. After crushing, always if you don't do the adequate crush, what happens? The multiple layers of stent hanging into the main vessel. So sometimes it's very difficult to cross. So you have to crush adequately. And when you are pushing balloon also, sometimes it may not go if you don't adequately crush. So that there is an adequately crush with adequately sized balloon and see that the crushing is adequate or not. This is another patient where a 64-year-old female, actually she has a strong family history of coronary artery disease. Her 4 brothers were having a coronary artery disease, non-hypertensive and diabetic, presented with unstable angina. For her, we did PCF LMCA, LED LCX, that is bifurcation T-stenting in 2014. And 2 years later, she came with classical angina and presented with ISR. This showed a significant calcification and unexplained the you can see totally occluded LCX. You can see the total occluded LCX stent and CTO of LCX. Then finally, we tried with multiple wires. Then finally, we could cross with Gaia wire. Then here, if you see the LCX, there is approximately 1 stent is there, distally 1 stent. In between, there is no stent. So our intention is to implant the stent to the bridged portion and do the DEB to the proximal stent, DEB to the distal stent, and do the kissing with the DEB. Because while doing kissing, I don't want to damage the LM to LAD. So 2.5 into 15 mm DEB balloon dilatation. So this is the first kissing. After kissing, then we acquired the OCT image. You see, after kissing also, there is an inadequate expansion. You see the area, if you see, LCX is still not expanding well. It's a very, very tight, 2.5 square mm, and distal 4.7, and LMC at 12 square mm, LED 11 square mm. And this is the interpretation after post-DEB kissing balloon. You can see the LCX 3.8 square mm, here 2.5 square mm, and distally 5 square mm, and LED 9 square mm. So this is significantly underexpanded. If you don't expand, the restenosis rate is very high, 89% versus 98%. So always try to aim, or if the vessel is big, at least more than 90%. And then we thought of doing cutting balloon. And this is LED image. We wanted to see how the LED distally calcific block is there, but the area is adequate, 8.8 square mm, 3.3. And LMCA nowhere is showing any evidence of restenosis. LMCA also 16 square mm, 12 square mm, and adequate areas. And this is after post-cutting balloon. Then we thought of using cutting balloon. Then we did the cutting balloon to the LCX ostium. Then you see the 5.6 square mm. We got the 5.6 square mm. Then after that, again, kissing was performed using the, this is a post-dilatation LED 3.5, LCX with 2.52 score flex. Then final areas what we got, 5.6 square mm LCX ostium and LCX the distal portion 6.0 square mm, LAD 9 square mm, LMCA 12 square mm. So when you are using a two-stent technique, if under expansion is there in two-stent technique, the restenosis rate is almost 46% versus 6% if you have adequate expansion. So always aim for adequate expansion, otherwise the TLR is very, very high. This is more so in a two-stent technique. But if you see the single stent technique, relatively less. And this final kissing 3.5 and 3 LCX was done despite achieving 5.6 square mm. We did with a through. So this is a final angiogram. So this lady, we did, this procedure was done nearly 3 years ago, but still she is doing very well. So when you are doing the bifurcation, it's very important to see what type of carina. Is it spiky carina or eyebrow carina? These are all very important. Once opposite side flow divider, if there is a significant calcium, when you are inflating, it can overhang the side branch ostium, it can crush and it can cause carina shift. It can lead to side branch occlusion. So more important, carina tip angle and that bifurcation point to carina tip length is very, very important. So bifurcation point to carina tip length, if it is less than 1.75, the chance of closure is very, very high. If the carina tip angle is less than 51% also, that is favorable. So always it's acute angle or not, that is also we have to see. And OCT also shows in LM bifurcation, sometimes if the alignment of the catheter is not proper, when you are not, when you are pulling balloons, it may suck inside, it may cause the longitudinal shortening. And when you are pulling the abdominal wire also, or if you are pushing the balloon over the abdominal wire, it can cause the longitudinal shortening of the stent, which is seen almost 6.5% of patients in Excel study of the left brain. So always perform the, like where to put the part, that is very, very important. You should know the expansion limits of the each stent, like a Synergy, Expedition, Resolute Onyx. So here, if you see what size you can go, 4 mm, like a up to what size you can say, like a 2.25 or 3.5, 4.5. Suppose if the 3.5, you can go up to 5 dilatation, also maximum balloon size. The 4 stent, you can go up to 6 dilatation. So majority of the newer stents, 3.5 can be dilated up to 5. So when you are acquiring the OCT, see that the catheter is very well aligned. Try to use the only single wire. And if needed, you can only partially keep the OCT catheter inside and partially keep it in the guide catheter. You can use the guide liner also at the mouth of the LMC ostium, and the flow rate should be high. Regular flow, we maintain 3 to 4 ml per second, but when you are doing the left main, maintain 6 ml per second, then the better resolution of the LMC ostium you can see. And areas almost 10 to 15% compared to IBS MLA. This is like a recent ESC guidelines diagram. So landing zones plaque burden should be less than 50%. And dissection, you should not leave. Always it's minor dissection less than 60 degree, less than 2 mm. And intimal dissection you can leave. Medial dissection, you should not leave it. And the distal dissection decisions are more dangerous compared to proximal dissections. And maloposition, 400 microns, you can, you have to address with upsize balloon. And 1 mm length also, you have more than 1 mm length also, you should address. Otherwise, when you are doing the next procedure, wire can go abdominally, and that can cause the balloons can go, it can distort the stent struts. So reference diameter, when you are using the IBS criteria, it should be more than 5.5 square mm inside the stent, in the landing zones also. Or if you are taking the reference diameter, at least you should achieve more than 80% area. Everywhere, OCT, if you are taking more than 4.5 square mm, you should achieve. And the expansion should be more than 80% remnant. Ideally, you should achieve more than 90%, but the target should be more than 80%. If the less than 70%, definitely under action. This is the diagram I made very clearly. the severity and calcification of the distribution, assess the LMCA, LAD, LCX, calcium depth you see, arc you see, length 5, and if the expansion index 4, then use the rotor, you can use the IVL, and luminal area along the length of the LMCA, LCX and LAD, plug burden at the LMCA, assess the LCX and properly evaluate the disease extent, plug burden, choose the proper landing zones, and based upon the landing zones, are you landing in the right landing zone? The choose the zone with a minimal plug burden. That means at least the arc should be more than 180. If we see plug less than 180 degree, most of the time plug burden will be less than 50%. If that is the reason Illumin has picked up, at least you should see EEL along the more than half of the circle, that is more than 180 degrees. So in that case, when you are seeing the EEL more than 180 degrees, that means the plug burden is less than 50%. And don't land in a zone with a lipid-rich plug. Most of the time ISR, though angiographically it looks nice, but in the follow-up, the chance of ISR is very high. Don't land in a place with a significant calcific arc more than 70 degree or fibrous plaque more than 50%, where the chance of restenosis rate is very, very high. So IVS and OCT should be considered in selected patient to optimize the stent. And there is enough data to say, particularly the IVS XPL study and recent, many studies have come, ultimate study, all these studies have shown very clearly, ADAPT-DS sub-study, all these studies have shown very clearly the MACE, particularly stent thrombosis, ISR, almost 50% reduction, 50 to 60% compared to angio-guided PCA. So imaging helps mainly in identifying the, choosing the right landing zone and under expansion. Many times, it's my personal experience, angiograph shows very good result, but when you do the imaging, many times under expanded stent will be there. So malopposition will be there. These will not be seen. Last time we were doing one live case, we did the V-stenting of the left main, that is LAD and LCX. Patient had a gross dissection, which was not seen. That's almost more than like a 120 degree dissection and nearly 600 micrometers width. So angiogram not showing. If you leave it, definitely these patients can die suddenly because of the stent thrombosis. So OCT in bifurcation, guiding bifurcation PCI, without mainly angiogram, particularly overlap lesions will not overlap sites. It cannot assess very clearly. Radiographic, angiographic lesions. Calcium also, we are not sure is deep calcium or superficial calcium or calcium nodule. So based upon that, you can choose the right strategy. So choosing the right landing zones and adequate length and adequate size diameter is very, very important. And assessment of the proper expansion, which is the single most predictor of the death outcome, and proper apposition without any malapposition, and evaluation of the management predictors of death risk. These are mainly any geographical miss, tissue prolapse is there, thrombosis is there, intra-stent edge dissections, intramural and extramural hematomas are there. If these are there, then you can identify, can address these issues. And last case, like a 65-year-old male presented with chest pain, as with shortness of breath, ACS and STEMI, hemoglobin 12.5, blood urea 14 milligrams per deciliter, serum creatinine 0.83, echograph no RWMA, and you can see the LAD. And here diagonal is looking very nice. Origin is, ostium is looking without any significant block burden. There is a long, this is the bifurcation assessment. You can see the bifurcation length, you can see the angles. And this is a favorable bifurcation angle. And you can see the left main and this LCX. And you can see the length, you can assess 28.5 proximal landing. And this is a post-angiosculpt because the patient has a severe, significant fibrosis. The post-angiosculpt, you can see the dissections very, very clearly. The block modification was done. Then this is the analysis and strut crossing and everything. And proximally, there is a very big, despite doing 4 mm balloon, patient was having significant malposition, which was not seen on angiogram. You can see angiogram looking normal, but there is significant malposition. So here, then we upsized with 4.5 MNC, then expanded up to 93%. So there is a 39%. This is a classical example where the angiogram looks normal. Many times, if you pull back the wire when you are placing, it will go subliminally. When you are passing the balloon will not go. This is one of the reasons. So this is the final proximal edge of the stent, MLA. 4.1, 4.2, we got it. That is 73%. This is before NC. So to conclude, the OCT definitely helps in assessing the lesion morphology, in choosing the right device, that length and diameters. And once you stent it, you can optimize the stent results with adequate expansion and correcting the malposition. Have you landed in the right landing zone or not? Suppose you have landed in a unhealthy zone with more of lipid-rich block with a medial edge dissection, better to cover it with a distal stent to provide the better long-term results. Thank you, one and all.
Very extensive talk. Any comments from the expert panel, Dr. Ajay, Dr. Uday sir, Dr. R.K. Jain?
Two speakers were not there. That's the reason I'm forced to fill that.
I know, Dr. Pratap Kumar.
Actually, I don't have a talk, but because Kaparthi and somebody else was there, then Ravi told, sir,
Yes.
why don't you speak? Then okay, I will talk.
Just a question. So when do you suggest a proximal crossing of the struts, or when do you suggest a distal crossing for the benefit of the viewers?
Any provisional stenting, better to cross if you are going for T-tap or that time you go distal crossing. DK crush initially go with the proximal, or if you are using the imaging, you see that link free. If you are going to distal, what happens? That time it may not be, the stent may not be at the carina. It may go through that. So there may be, that lead to a stent distortion. So more and more pushing up the stent toward the branch, toward the left main side. So the second time when you are doing it, you can cross mid or distal. Ideally, you can go with mid or distal. But always OCT, when you are using the image, if the link-free carina is there, that is, suppose if you want to cross proximally, but there is a full of links. Sometimes if you have not adequately crushed. Recently, we had one experience. All the time, wire going through the almost multiple layers of the crush portion. It's not allowing the balloon. When it's not allowing, then we took the, again, Sasuke catheter. We were having a 2-3 Sasuke catheters. And then we tried to, we entered through another strut, and then we tried 4 or 5 times balloon, wire was going, 1.5 balloon going, but other balloons are not going. So this can happen. So when you are not crossing, choose the another strut. It's not the definite rule, but the guideline says provisional distal, DK, crush, go proximally. And if you are using the imaging, do the link-free strut. That is very important. Ultimately, more important, expansion, the strut should be away. It should not cover the side branch ostium. When you pass the balloon should go freely, and that even both sides all around, like an entire circle, the ostium should be covered with the stent struts.
Any comments from the expert panel?
Ajay, you are any? I think
perfect, sir. Great comment. As sir has said, the basic premise to be followed in a decay crush crossing is a non-distal cross. If one crosses too distally, you might push away the side branch stent from the carina, and then that is, you don't get the good results that you are supposed to. So as long as one remains non-distal, that is the best strategy. If one has got imaging to choose and decide exactly where you cross, that's fantastic. But even if it is not available, then the joy of the decay crush is that you can. It's a very, very forgiving technique if done well. And remember, the 2A recommendation for the imaging is for PCI optimization. So we are as yet not having adequate evidence to say that we should be pre-imaging everybody. And there is a significant, I'm not saying that that's the right way to go about it as we are learning about imaging, But there is a significant number of operators who are using imaging only at the end for deciding whether optimization is perfect or not. That means correcting whatever expansion. And there is a large body of interventionists who actually say that the current generation of stents are so forgiving that as long as one has got the sizes correct and one is able to expand them properly, they do a single imaging at the end and then finish with it. This is not what I do in my lab. I'm just presenting a different point of view. But the point about non-distal cross is definitely very, very valid, as Sridhar sir has said. Distal cross is basically meant for provisional, so that whatever the angle, you do not, you shy away from creating a neocarina at the bifurcation point, so that you have minimal struts at the carina, because that has been shown to have the best long-term outcome. If one actually crosses through a proximal strut, then one is left with either culotte or a mini crush as the strategies when one is trying to go from main branch into side branch. And those don't have the same elegant results in the long term as a well done tap TN protrusion.
Nice comments. So if there is no further comments from the expert panel, since we have just crossed the time, I would request the next moderator, Dr. Sujata Madam, to proceed with the keynote lectures.
I think we've come to the final session. There are certain changes. So I request Dr. Anand Rao to be on the panel. I request even Dr. Kasturi and Dr. Ramesh, Dr. Ajay Swami and Dr. Rajendra Kumar, if they have no commitments, to remain on the panel. For this session, we have 3 talks. One talk is imaging and bifurcation PCI. I think Dr. P.K. Sahu has joined in. And then we have Dr. James Christopher Samuel Spratt. He's also joined us, and he's a consultant interventional cardiologist and at St. George's Hospital NHS Trust, and he's the main referral for CTOs as well as for HOCM. Welcome, sir, for this keynote session. And of course, we have Dr. Sridhar Kasturi, who is, apart from being the organizing secretary, is proven to be the man of all seasons, pinching, giving so many talks when there are no speakers around. So let's start right away. I think Dr. Sahu, are you ready, sir? Dr. Sahu.
Dr. Sahu, are you ready?
Sir, Dr. Anand Rao, sir, is also with us, and he's a senior interventional cardiologist.
Good evening, Anand Rao.
Yeah, good evening. Good evening. Very nice talk, Dr. Kasturi. My compliments. Wonderful talk.
Very much.
Looking for more.
Can I share my screen? Is it visible?
Yes.
Yeah, visible.
At the outset, thank you, Dr. Kasturi, for inviting me. But the best part is that you have covered most majority of my talk. So it makes my talk very simpler, actually, in fact. So in fact, you have showed exciting cases, interesting cases. So I'll just give you a brief overview about what is the role of imaging in bifurcation lesions. Now, bifurcation lesions as such takes quite a long time to do. We have to choose the exact strategy that is to be done. And there we sometimes really think whether imaging is really required or not. Now, why do we need to do imaging? Because you see, bifurcations are usually complex. And whenever, if you don't dilate and just put a stent, there's always a carinal shift if this angle is an acute. This carinal shift is what we call as the snowplow effect is there if you try to balloon it out. And then the problem starts again to recross this thing. So if you have a good imaging just before you start putting your stents inside, then definitely you can plan your strategy. Here you try to see what is the proximal diameter, what is the distal diameter, what is the side branch diameter, what is the angle as has been described. So all these things do matter in the long run. Now, very simple example, someone was trying to do a single stent with an oversized stent, trying to push it. You can see how the side branch has got totally occluded. So this is, and then here it becomes very difficult to cross to the side branch and then complete the procedure. And if this is a big side branch, as you can see, it is more than 2 millimeter in size. Now, what do I look for while doing an intravascular imaging? Definitely the bifurcation site, the plaque location, the plaque burden and morphology. It helps me deciding whether I have to debulk it or whether I just have to use what is the modality to be used. Then the bifurcation angle between the main branch and the main vessel and the side branch. And of course, the vessel diameters, and these have all been highlighted by Dr. Sridhar in his talk. Now, I'll divide my talk into 4 main parts. What to look for in an IVUS. Is OCT better than an IVUS in bifurcation? Just to compare in one case where in a bifurcation where IVUS stands and where OCT stands. And because nowadays we are more into HD IVUS, how it improves the imaging quality. So this is an overall discussion that I'll be do. First of all, what do I look for in an IVUS? In an IVUS, if we can first decide what we call as the IVUS medina, we have usually an angio we start describing, and sometimes we miss the plaques. The plaque distribution appropriate characterize the lesion can be done what we call as IVUS medina. We can see the extent of the side branch disease, especially for osteal lesions, size of vessel diameters. Most importantly, as Dr. Sridhar has told about the recognition of the IVUS eyebrow sign. And this eyebrow sign is a presenting marker for side branch compromise. One has to be very careful if you get this sign. Don't under or overstretch the LMCA. If you put it less than 5 to 5.5 millimeters square, there's every chance you'll have an early thrombosis. So these are the things that you see prior to doing your intervention. Then try to achieve the targeted values in LMCA. LMCA bifurcations, you know whether there is under expansion. More likely so in 2-stent strategy where the LCX is usually affected. Once you put the LMC LED stent, you will see the LCX is pinched and then you have problems. Now this is a typical eyebrow sign which you get, and in this eyebrow sign you can see if you have something like this, be careful, you're going to pinch the side branch and you might have problems. So this is something one has to be careful about. Now, what are the values that we should finally get on the results? Is that validated in IVUS studies only. We do not have OCT studies to validate this data. For the small population, small person data, which are Asians, that should be at least a 5, 6, 7, 8 formula has to be followed. But if the larger population, larger person who are this thing, we can have go 1 higher up, and also the left one we can go to 10. So this is something which the data has been shown and has been proved in various IVUS studies. Then let me go and try to discuss whether OCT is better than IVUS. Definitely you will see OCT as recommended by the European Bifurcation Club. It is the use of OCT for treating bifurcation is much better because of the various reasons like the pre-dilatation, whether it has to be done or not, and how well it was done, assessment of the stent position, evaluation of malposition, calcified plaques, detection of thrombus, evaluation of wire position in stent recrossing, evaluation of side branch ostium, and providing better images of the lumen surface. Now, OCT, most importantly, is easier to interpret than IVUS and may be superior to IVUS in all these attributes. And these are the attributes that we see in a bifurcation. Most importantly, co-registration available in an OCT, and as a result, it eliminates the ambiguity that we get from angiograms. It minimizes the geographic miss during the stent placement and enables enhanced precision and enables high accuracy in stent placement. And this is what you want, especially in a bifurcation. And this has already been discussed by Sridhar sir regarding the various measurements that are to be done in the side branch and main branch. We see the distal reference site, we see the carina tape, we see the proximal branching point, the proximal reference site, the side branch angle, the CT angle, and the BPCT length. So these 3 criteria has to be analyzed in every case of bifurcation that we do. Try to enlarge the views and try to see what it is, because it has been shown the long-term results are good if you achieve the targets. Now, most importantly, OCT systems are equipped with software where you can really know where you're crossing the wire. You can visualize the morphology bifurcation and can enhance the stent positioning, and it can help identify side branch, any complications, coverage, and everything can be seen if you do an OCT. Now, more importantly, in detecting malposition, there is an apposition indicator which can tell you whether this rendering of the stent can be done and can show you that definitely your stent has apposed well. So this is how OCT is much superior than an IVUS. Now, let me just show you 1 or 2 cases about how we compare IVUS versus OCT. The first case, you see, this is a young gentleman who is a TMT positive. You can see the LED diagonal diseased, but somehow we thought that first we would just do a provisional one for the LED and leave the diagonal because it doesn't, of course, looks something but borderline, but it was quite a large artery. And this is what you see, the moving diagram. You can see that the LAD and diagonal are diseased. There's some amount of calcium here also in the LAD, which is visible on angio. Now the RCA was normal, and I first did an IVUS to see, and you can see there's almost a ring calcium with good amount of plaque in the LAD. So this had to be debulked, and what we did was first also did an FFR to see the LAD was significant, it was 0.74, did an FFR of the diagonal 0.70. So we could plan a strategy that now we have to go for a bifurcation stenting in this case. So the plan was to debulk it, that is rotablate the LAD because it's very superficial, then bifurcation stenting with the LAD diagonal and do a decay class. So first with the 1.75 bar, we did a rotablation of the LAD. The LAD rotablation was done, the debulking was done, and after the debulking, the decay crush was used to put the two stents, and finally this was the result. In fact, there are two stents in the LAD and one in this thing that is diagonal, and this was the pre and the post results that you can see. The results are good. So strategy wise, definitely imaging does help. And then here you can see the crossing of the side branch wire. Of course, not a great cross, but definitely you can see how it is crossed. And finally, the stent rendering or the apposition indicator showing that the stent has been well apposed, the pot has been done, and that the results are good. And this is the OCT run of the LAD to show that definitely the run shows that the stent is very well apposed and it is well expanded also. This is just to show that how OCT helps in a bifurcation. And next, this is just that if you compare, I did an IVUS in this case. If you see the OCT, you see the stent here is very well apposed and expanded. You can also see the similar thing on an IVUS. This is the OCT pictures and these IVUS pictures. It is not that IVUS cannot give you the exact picture of the bifurcation, but definitely with the new HT IVUS catheter, the 60 megahertz catheters, the imaging is also quite good, but they may not be as good as the OCT where you can see everything. This is very important. And most importantly, to see the carina, the diagonal and the LAD, you can see over here. Here is the same case, which is the IVUS has been done. You can see the LAD and the diagonal, and you can see how the stents have been opposed. So you can also use them as IVUS as a modality of imaging, but definitely the data that you get from this thing, OCT, is much greater than what you see on an IVUS. Now, let me come to the fourth point that I have to discuss, HT IVUS. Are we improving the image quality? Because now we have all shifted to HT IVUS. And if you try to see, this is a case of a bifurcation in which there is a large diagonal, LAD diagonal, which was planned for a decay crush, and this was a decay crush which was done. And this was done around 4 months back, in fact, and this was the result that we see. And if you try to see the HT IVUS, this is, you see, the image on the HT IVUS are much clear. And this is the LAD to LAD pullback, where you can see the LAD and the diagonal very clearly you can see. And this is the diagonal pullback, where you can see also the diagonal stent is well opposed. Sometimes if you compare the this thing that is the IVUS versus the OCT, you can also clearly see the strengths as you can see in the OCT. So HT IVUS have definitely some advantages in imaging and also seeing what is good and how well you have achieved. But of course, for calcium and all, definitely OCT will score much better. So to conclude, which intravascular imaging modality to choose for bifurcation, these are my personal views. Definitely, as you have shifted to HT IVUS, definitely if there's a LMCA disease and the vessel or any vessel where the size is more than 5 millimeter, I'll always use an HT IVUS. I'll not depend on an OCT. CKD patients where I have to do a minimal contrast angioplasty, and IVUS is definitely preferable. LV dysfunction, I'll definitely go for an IVUS. Contrast limitation, where I have to do multiple runs, large vessels, where I do not want to push much contrast, there I have to go for an IVUS, because you have to, ultimately you have to have a perfection that is to be done. So definitely it is better to use an IVUS. And the fifth reason is that the clarity of the carina that we get is almost comparable on HT with an OCT. So it is not necessarily that you should always depend on an OCT. You can also do on an HT-IVUS and try to show large vessels doing multiple runs. And OCT, of course, definitely to do the good carinal main branch, side branch assessment. Calcification assessment is always best done with an OCT. You can know what is the type of calcium and how do you debulk it. Then side branch wire crossing is best seen on an OCT, which is best seen stent expansion. And most importantly, the apposition is very well visualized on an OCT. And finally, any complication like dissection, even a minor dissections are picked up in OCT. So we have 5 advantages of using an HT-IVUS, 5 advantages of using an OCT. So you have the judicious in what you're using, in which case, so that you ultimately give good results. And finally, as you say, it is angioplasty done with confidence. Thank you very much for your patient hearing.
Thank you, sir. Thank you for the elucidating the use of HT-IVUS. Sir, Dr. Anand Rao, sir, you have any comments? Sir has proposed even HD-IVUS now.
I personally feel my experience with HD-IVUS is very small, but I think the images are absolutely fantastic. We are able to see more and more clearer. But if the person has started his career doing OCT, he will not understand this. But we all started our career doing IVUS. So I still have a very, very soft corner and a very passionate about doing IVUS on this thing. Dr. Sahu,
Yes.
what about osteal locations and anomalous origins of the coronary arteries? I mean, if there's an anomalous origin, if you're not able to hook the catheter properly,
Yes, all right. See, there are various ways. It is not that you cannot move the OCT catheter or the IVUS catheter, but definitely the IVUS catheter moves in better. Now, if you have an anomalous origin, try to take your catheter over this thing that is guide liner. That is something which you have done. Even you can use a body wire to reach your catheter inside in an anomalous origin also, and then take out the body wire and then take a pullback. But sometimes what happens when you have an anomalous origin, the guide catheter, if it is not well engaged, you won't get good OCT images. But this is a positive point for this thing that is IVUS, where you can really get good images in an anomalous coronary.
Yeah. What about osteal locations?
Osteal, yes, or LMC osteal, I always use an IVUS. I do not use an OCT, but people have been using it. But definitely, I find the HT-IVUS very useful in an osteal LMCA.
Sir, I would like to ask the expert panel if you always do an OCT to look where your wire has crossed before you proceed with the procedure further. Dr. Spratt, Dr. Kasturi, and Dr. Sahu.
I will tell. I've been discussing this with various people. The frozen images actually look very good, but practically to do, I want to ask how many times you are going to do the OCT to find out which strut you're crossing. So practically, I think my own experience is I would if I cross it very distally, I would keep the wire, and I see on OCT if the wire is distally, I would keep it there. I would not repeat an OCT. I try and take another wire and move it proximal to that.
See, what I would suggest is that supposing you don't want to push many contrast, definitely I understand it's a very tedious process. The best thing would be to cross it a wire, take a small balloon and just do a stent boost. Then you can, in triple mag, you do it, you can clearly know which strut you have crossed. So you don't have to really go for an OCT to know which strut you have crossed.
Dr. Spratt, would you always do an OCT to see where your wire has crossed?
I think we never do always, and we never do never. But at the same time, the question is relevant if you think the crossing is relevant. This is actually something which has been addressed within a study called October, which is an OCT guided bifurcation study run out of Eval Christian's lab in Denmark, which we're contributing to. So that actually mandates that you have to define crossing, and it mandates that your wire crossing has to be specific to the technique used. I think this conversation is great. I'm among imaging enthusiasts, and we're preaching to the converted here. I think there's probably a bigger ticket item, and that is the vast majority of patients don't get anywhere near intravascular imaging. So I think sometimes when we have these conversations about distal wire crossing, we run the risk of almost scaring away people who don't do any intravascular imaging. Now, the last lecture was a great example of the benefits of both OCT and IVUS, but both OCT and IVUS offer massive advantages over angiography alone. So I think that's, to my mind, is the important learning message for your delegates, that actually if you want to get long-term results, if you want to get durable results, you have to do the procedures to this level of detail. And if we're discussing about where the wire's crossing in a 2-stent bifurcation, I said that's a level in which most people aren't doing at the moment. So I think it's the right direction of the conversation. I think the bigger fight is convincing people of the necessity for imaging in the majority of cases. And certainly in my practice, I'm as close to 100% for intravascular imaging. Maybe the odd case I don't, but the vast majority, I'm primarily a complex PCI and CTO specialist. So you can see the benefit lies in there, but I think this is the right area to have the conversation, just to completely reinforce the need and the utility of any form of intravascular imaging.
So any bifurcation PCI you would use, you don't do without imaging?
I don't do any case without imaging. The question I ask myself is, if I was on that table and somebody was doing my PCI, and I just would I want them to just guess about the stent? Oh, that looks okay, that looks fine. The answer is no. I want them to do a good job. I want to know that there was no micro dissection. I'd want to know there was no malapposition. I'd want to know that the stent was expanded. I'd want to know the final stent area. Maybe that makes me fussy, but I know the data is increasingly of the mind that we can be very predictive of procedural durability, but only if we get the stent to the right area, and only if we don't cause a complication of our procedure. And I think anything short of that is just guesswork. And I don't think we're at that stage anymore that we can take chances or guesses with our patients. So actually, bifurcations is yes, I do imaging bifurcations, but I do imaging in calcific disease, I do imaging in left main, I do imaging in CTOs. There really isn't a differentiation there. I think there was a very interesting point in the lecture before last in which the point was made was some people just do imaging at the end of the procedure. Now that's something I refer to as an imaging endorsed procedure, where you stick a catheter down and, well, I've done imaging, so therefore it's like a magic wand. It's not a magic wand, it's information. So you get the information at the start of the procedure to understand plaque morphology. You get it after you've modified plaque, such as the last case, you rotablated, you want to make sure that was effect. And you get it at the end once you've optimized your stent. So if you're going to make that investment, you do it systematically at the start, at the middle of the procedure, and at the end of the procedure. And that's a proper image guided procedure, not an image endorsed procedure.
Sir, I would like to just point out that even a big trial, a randomized trial like an Excel trial, used imaging in just 70% of the patients. And they are not used like you are telling us, like pre-post. So like
shambolic.
Yeah,
shambolic. We quote Excel, and the 3-year data from Excel and IVUS was actually very convincing. You look at the 3 tertiles, and if you're in the highest tertile in terms of area, there was no stent thrombosis at all. And the lowest tertile, it was nearly 4%. So actually, and that, as you say, quite correctly, there was at least 20+% of patients who had no imaging. And actually, if you look down in terms of systematic use of imaging, it was much, much lower, less than 40%, I think. So for me, the big area we've got to push at moving forward is move away from this individualized care. We should be systematic about how we treat patients. There shouldn't be a patient we try a little bit harder than another patient. They're all worth and due the highest quality of care. And I think Excel showed us the direction that we have to go into, but I think it should be much more systematic approach. And actually, that's probably why we're still struggling to match the outcomes of coronary artery bypass grafting, not just at 1 year, but at 3 years and 5 years. It's not good enough for our patients to say, okay, you didn't get any complications. We want them to get a durable result which lasts 5 years or 10 years. And I think that's achievable, but only with the care and attention and systematic approach that we're all talking about today.
Thank you, sir. I think you have emphasized the systematic approach, just not do pre or post and just get away with it. Yeah. So I think we would like to invite you to this lecture. I think, sir, are you sticking with your talk? Optimization of PCI of calcified coronaries?
Yes, I've got something on calcium, so I'll share that with you now.
Thank
you. Hopefully you'll see that on screen.
Yeah, able to see.
Yes.
It's kind of a wee bit funny, so sometimes you can see that okay? So my name is James Spratt. I'm a professor of interventional cardiology at St. George's in London. I specialize in complex PCI, CTO PCI, and I'm very pleased and honored to be asked to your fantastic meeting today. So I've heard some great lectures already and hope to be able to add to that. So let's have a look about our procedural goals in contemporary PCI. So we want to be efficient, and efficiency is perhaps something which is kind of overtaken the discussion in PCI. So we want to prepare the lesion and prepare the stent without damage to the stent struts or the drug coating. We've been talking about this already, but we want optimal mechanical results, and that means appropriate stent expansion, and we want a good minimum stent area. And we know that minimum stent area is the single most important predictor of stent thrombosis and stent restenosis, and there's an increasing body of evidence supporting that. But in the pursuit of that goal, we want to be safe, so we don't want major complications. And we were talking about the systematic use of imaging, and I think that data is becoming increasingly persuasive in that effect. And we now know exactly what we should be looking for. So again, the MSA that I've referred to already. We want to avoid proximal malapposition. We don't want to land our stent in too much plaque, either proximally or distally. And we want to avoid dissections which could lead to acute vessel closure. So coronary artery calcium is a major issue. You've got a diagram on your left of a severely calcified lesion. So how does it impact our coronary arteries? Well, of course, it can lead to incomplete revascularization and procedural failure. As we try to modify it, it can lead to procedural complications. And you can see this is a pooled analysis showing that the presence of coronary calcium is a predictor of complications and a predictor of success rate from this Horizons and Acuity pooled analysis. So we want to avoid target lesion failure, and we want to avoid major adverse cardiovascular events. And again, there's this consistent relationship between not just lesion failure, but also death and cardiovascular death as the level of calcification increases. And this is a more updated analysis from Greg Stone's group showing much the same. This was designed to compare first generation and second generation drug-eluting stents, but the main message is that a high burden of coronary calcium leads to a higher incidence of major adverse cardiovascular events. And that happens not just acutely, but it's an increasing trend out to, in this case, 5 years. And a further analysis showing much the same, that there's this graduated appearance between moderate and severe coronary calcium. And again, this is angiographic rather than imaging-based parameters of calcium. So you might well ask yourself, well, why is that the question? Well, it's primarily an issue of vessel compliance. That's what calcium causes us problems. And calcium is a poorly compliant structure. So in other words, with the same amount of pressure applied to it, it does not change in volume in the same way as a fibrotic or a hypoechogenetic plaque will do. And it impairs or prevents delivery of secondary equipment. That leads in turn to a requirement for high pressure inflation or specialized equipment. And if that lesion hasn't been prepared properly, that can lead to strut or polymer damage and therefore impaired drug delivery. And again, if the lesion hasn't been prepared properly, you can get under expansion of the stent, and we've talked about already what that may lead to. So if we ask ourselves, well, what are the goals of calcium modification? The primary goal is to restore vascular compliance and to ensure adequate stent expansion. That'll in turn prevent damage to struts and drug delivery, and it'll improve procedural efficiency. So let's look at the therapies that are available to us. Well, the ones that we're all very familiar with are all primarily balloon-based. NC stands for non-compliant. OPN is a particular type of non-compliant balloon available in Europe, which can be inflated to 50 atmospheres. Scoring balloons, you have the wire external to the balloon, which causes a scoring type effect. And the cutting balloon has got these kind of flexotomes or little mini blades on the surface of the balloon. Atherectomy comes in two forms, rotational atherectomy, which has been around, of course, for a long time, or orbital atherectomy, which is a bit newer. And lithotripsy is the latest entry into the market, which has got its own specific mode of action, which I'll come on to in a moment. So ideally, we want all these things. We want to restore vessel compliance, but we don't want to do that at the risk of complications. And of course, ultimately, the complications, if they do occur at the index procedure, they'll offset any potential benefit that you get when you just deploy the stent properly. So you want to maximize the ability to modify the calcium and minimize the problems at the other end. So what happens if you inflate a balloon? So here you have a balloon, you've got eccentric calcium between 9 o'clock and 3 o'clock. And often you get a tear at the interface between the calcific plaque and the non-calcific plaque. And actually, if you look at plaque morphology, calcium is a predictor of both plaque stability and also plaque instability. So if you get spotty calcification, it's actually a predictor of a plaque that's likely to rupture. Whereas if you get sheet calcification or plate calcification, it's a predictor of plaque stability. And what we want to do, ironically, within a device-based procedure is to actually make a very stable calcific plaque. We want to fracture it. So we want to do what we don't want to happen normally in nature. And balloons preferentially expand away from non-compliant structures, i.e. the calcium. And the high pressure balloon inflation is often causes tears or major dissections and sometimes even perforations at the interface between the calcium and the compliant tissue. And there is, of course, a variance between what these balloons can do in terms of their ability. There is actually some data behind cutting balloons being a little bit more effective in terms of their ability to specifically target calcium, but none of them target deep wall calcium very well, and none of them really modify calcium in the presence of eccentric calcium. They can if it's concentric and thin, but not generally that well in eccentric calcium. And there's an example of some of the data with cutting balloon versus a conventional balloon. What this data is showing here is, first of all, it's looking at calcium fractures as a measure of efficacy, and I'll come back to that in a second. So the more fractures you see post-balloon modification, the more likely it is that you've restored vessel compliance. So essentially, you're using anatomy as a surrogate of physiology. And you can see that cutting balloons will target thicker calcium and they'll result in more calcium fractures. And they'll actually even slightly outperform the more targeted therapies such as scoring balloons or non-slip element balloons. So here's an example of, this is myself and Colin Hanratty doing a live case to an American meeting. And this is after bifurcation, ironically, in which we'd started with a cutting balloon. And you'll see as we come back to the bifurcation, you can see eccentric calcium from 12 o'clock to about 6 o'clock. This is HD IVUS. There's your wire coming in from the diagonal here at the branch. And at this point here, you can see severe tears in the calcium, large dissection plaque, and a false lumen. And that's consequent on the cutting balloon. So big dissections. You might say, well, that's alarming, and actually that's what you want to see. That's a sign that you're now ready to put a stent in. But it is also a sign why you might want necessarily to use an OCT in this situation where there is a big dissection flap already. And often we'll do imaging rather than doing any angiography at this point. So with atherectomies, again, there are specific considerations. First of all, they require a dedicated wire. Secondly, the thermal injury can cause platelet activation and lead to increased clotting. That's even more of a risk in the context of an acute coronary syndrome. And that in turn may contribute to distal embolization, which is sometimes partly calcific, sometimes platelet. And that slow flow or no reflow can lead to periprocedural MI. In terms of its efficacy, the ablation is contact dependent. So therefore, the bigger the lumen, the harder it is to ablate. And root ablation doesn't modify deeper wall calcium. If you've got a bifurcation, you've got to give up the wire because you can't root ablate with the wire in place. And of course, the risk of transection of the wire or dissection of perforation and tortuous anatomy is also a consideration. And these considerations are probably held across orbital. There's a relative risk and benefit between the two, but they both have a degree of limitation in that. They also require a degree of expertise, and that expertise is probably the biggest thing that has limited their market expansion. It's still relatively small, certainly in Europe, certainly less than 10% across centers. Lithotripsy, by contrast, not require specialized wire. And because it's a balloon-based therapy, I think that does make it easier for people to adopt, particularly in bifurcations, and that's relevant to our discussion today. You can protect the side branch with a second wire. The shockwaves are selective for disrupting coronary calcium. They will pass through non-calcific plaque, and they will modify deep wall calcium. And that calcium stays within the wall, and the risk of distal embolization seems to be very low. And because you can perform that calcium modification at low pressure, there probably is a reduced risk of high pressure inflation. So here's an example, again, in a bifurcation disease. You've got a 1-1-1 bifurcation, severely calcific disease, a little bit of aneurysm formation at the diagonal origin. Constrained non-compliant balloon, the proximal AD, also in the diagonal. So this is high pressure NC balloon. Intravascular lithotripsy proximally, leaving wires in both places. And this is a very important learning point in that following lithotripsy, we need to do some form of imaging to confirm that there's modification. And you can see this classic fracture, often deep wall fracture extending into the media. When you see this fracture in play, you know that you can move on and implant a stent as required. And that's a result after a 2-stent treatment of the bifurcation. So in comparison to balloon-based therapy, it's very intuitive. It has a slightly bulkier crossing profile. So sometimes you want to combine it with rotational atherectomy up front. It doesn't require high pressure inflation. There is a degree of thermal injury, but it's extremely low. And there's a very low risk of distal embolization. And it does modify deep wall calcium very well. And compared with rotational atherectomy, I think the main take-home message is it's probably got a lower risks in terms of complication, and it's certainly got a lower learning curve. Complications, I think any new therapy, you have to take this with a pinch of salt, but they seem relatively low in terms of dissection and acute vessel closure, and certainly embolization and perforation. And we've modified this into our algorithm. I'm very happy to circulate this around. So it starts with angiographic assessment. If you can cross with an imaging catheter, I would suggest doing that before predilatation, but if you can't, you would go first to rotational atherectomy. And then you're seeing a more detailed measurement of the type of calcium. Is it concentric, greater than 180? Is it nodular? Is it thin? Is it thick? And that'll determine which modality you use. And the thinner it is, the more we'll go to more conventional therapy, like NC balloon or screen balloon. The tighter it is, the more likely it goes to rotational atherectomy. The thicker and the deep wall it is, the more likely we'll go to lithotripsy or shockwave. And if we can't cross, we'll go to rotational atherectomy first of all. And the key point is after this, we check with imaging. And if there's no modification, then we have to repeat. If there is modification, then we can go to balloon-based therapies and finally stent implantation. Thanks for your attention. That link is to lots of other videos and material which you can access for free on the Wonder Medical Net under my educational company, which is called Optima Education. So thanks for your attention.
Thank you, sir. So after the calcification modification, you are suggesting that we repeat the OCT. So we can see fractures obviously on the IVL, but how do I know that I did a good rotational atherectomy? Because most of the time we don't see fractures. How do I know that my rota is good?
Yeah, I mean, that's a good question. I think the first thing to say about the fractures is that in the recent CAD3 study, which is a lithotripsy-based study, the fractures weren't seen in about a third of cases. And I think even with OCT, there's a limit of resolution that you don't see microfractures. There's some interesting cadaveric work coming out of Romani's lab showing that you can see fractures at a microscopic level, which we won't see on imaging at all. So I think the obvious surrogate for efficacy of any form of calcium modification is appropriate expansion of an NC balloon. So sometimes if I don't see obvious fractures, we showed a very, an obvious example in OCT, we'll use a 1-to-1 size NC and make sure that there's proper expansion after that. Because if you get that and you repeat your imaging, you'll see fractures at that juncture. Essentially with calcium, you're looking to see plates which move apart. You don't change the compliance of calcium. All you do is create fractures to enable the calcium to move apart a bit like plate metal.
Dr. Anandrao, sir.
I want to ask, first of all, Dr. Smart, congratulations on that wonderful talk. My question to you is, if you are using a IVL therapy, is it mandatory to sort of do imaging?
Well, I mean, that's a good question. First of all, nothing's mandatory. We don't get told what to do. As you may have kind of got the impression already, for me, that's a bit of a problem. I think we should be told what to do more often. To my mind, there's two answers to that question. If you ask the company, they say, no, imaging is not mandatory. You can do lithotripsy and use the methods that we discussed as well, use NC balloon as a surrogate marker of efficacy. And certainly you can do that. I think in the kind of cases where you're looking for calcium modification, these are high risk complex cases, and it really does matter the stent results you get. So for me, that there's a very good reason to use imaging. And when you do use imaging, why not use it for every step of the procedures? So if I do an IVUS-based case, there'll be minimum of 8 runs within the case. And if I do an OCT, well, again, we'll use multiple runs as well, and we'll try to use guide extensions to minimize the contrast. But yes, if I use lithotripsy, I use imaging. But if you ask other people, they'll say, well, you don't need to. But my view is you should.
Yeah, because I asked this question, if use a lithotripsy and if it's not a 360-degree calcium and you do a lithotripsy, and what happens to the normal side of the vessel? I mean, does it get ablated? Does it get aneurysmal in the long run, or what is it?
Nothing really is the short answer. So lithotripsy essentially is a cavitation bubble that's created by stopgap technology. So it really causes it's equivalent to a pressure balloon of about 60 atmospheres, but it has very little effect on fibrotic tissue or lipidic tissue. So it just essentially dissipates. And that's one of the reasons why concentric calcium is actually easier to treat with lithotripsy than eccentric calcium. There is a dose-dependent effect. In other words, you're going to have to use more pulses to modify eccentric calcium. But unfortunately, we're at the stage that we actually don't know what that dose is. So it's a bit, you know, there's a lot of data coming out. We've published, I think, about 10 papers on lithotripsy already, but all of us know by clinical intuition that eccentric calcium takes a higher dose. We don't know exactly what that dose is, but certainly concentric calcium is actually easier to treat than eccentric calcium. And I think the hardest bit to treat, the hardest calcium to treat is nodular calcium. And I think that's also the most dangerous to treat because it's often associated with a perforation risk.
If we have nodular calcium and let me say my rota is not towards the calcium, it's away. So would you suggest using IVL or what do you suggest?
Yeah, so I think, again, that's a great question. I think that's the area that we're really, the area of calcific management that we're struggling the most with. Now, I would refer you to the same website. I have a friend and colleague who works in Sapporo in Japan, Yoshi Kashima, who calls himself the Rota Monster. And he has a whole, he loves rotational atherectomy. He lives for it. And he has a whole lot of techniques to deal with the problem that you discuss, really. And of course, you're talking about wire bias. How do you manage wire bias? And how do you ablate when the wire bias is the opposite side from the nodule? Well, one thing is you can change the rotor wire from floppy to stiff. That can change it as well. The second thing you can do is change the rotational speed, because if you pass, first of all, with a high rotational speed to ensure safety, I'm sure you can cross without getting stuck. You then can reduce the rotational speed. And what that does is increase the axis of rotation. And you almost turn your rotablator into an orbital type device, where you get almost a kind of ablative effect in a kind of sort of elliptical way. So that would be my first port of call, because I think that if we've kind of moved away from debulking, but nodular calcium is about the area where we haven't moved away from debulking, that you really do need to debulk. So I would spend longer with rotational atherectomy rather than shifting to lithotripsy in the presence of nodular calcium.
Dr. Ajay,
what about case reports of ventricular arrhythmias with IVL?
Yeah, so you're asking the right man again. So we were the first group to describe the shock topics in terms of the lithotripsy produces an electrical coupling effects. It can actually pace the ventricle through something called electromechanical coupling. And that's a pulse related effect. So in other words, if the pulses are every second. So if you've got a heart rate less than 60, you can capture the ventricle for the duration of the 10 cycles, so up to 10 seconds. So there is two scenarios which can be associated with potential risk. Scenario number one is you can electrically capture the ventricle, but not mechanically capture the ventricle. And in the presence of a pacemaker, that can lead to pacemaker inhibition. So you can potentially get asystole for up to 10 seconds, which is maybe not that long, but you could obviously stop pressing the button and that would stop it. Now, there has been one case report of VF in the context of lithotripsy. And again, that's a hospital where I go to teach people CTOs in. So I know the case quite well as well. In that particular case, it was an elderly lady with severe pulmonary disease who was also having rotational atherectomy to a right coronary artery and had a lot of ischemia. So it's potential that the lithotripsy was contributory, but it's not certain. And that's the only case report to date. And I think when we looked at the safety profile, there was something in the range of 20 million pulses in terms of what's been done to date. So if there is a potential risk, it's tiny, and it occurs in the context of interventional cardiology. We're in a cath lab where we see people who have VFRS quite frequently, and we can deal with it. So I don't think it's a big ticket item, but I think it's something to maybe be aware of, and let's see what the data shakes out over the next wee while.
Dr. Ajay Swami, you have anything to say and do you have any questions to ask, sir?
Great discussion. Really enjoying the discussion, and I completely agree with the calcium nodule point. And it's something that we're learning as we go along. We actually cut down our revolutions on the rota to about 120 instead of the 150 to 80 that we normally use. And there is some study, some work coming out of Japan which shows that the MLA is actually better with slower rotations. And also the kind of imaging that we use, we always prefer OCT because it shows us the depth of calcium. And what we do now is, we do the ablation and then pass the workhorse wire beside it, do the OCT. And then if you want to go back in, you can go back in with a bigger burr if you need to, otherwise come back out and finish the procedure. And we always use plaque modification after rota. And we are very partial to using cutting balloon. We are very partial to using the angioscalp, and also sometimes the OPN in case it's required. IVL, unfortunately, in India is 6 times the cost of rota. So, although we have used it for a couple of patients, I mean, it's a funny company policy that doesn't allow us to use it as frequently as we would like. But the imaging is absolutely key in deciding. When the calcium is more intimal and, a little far away from the adventitia, I think rota is a great tool. And when it's a little deeper, then I think the IVL, when it is concentric and more than 200 degrees or 270 degrees or whatever you want to measure, then it gets better. I've been trying to talk to people to see if we can get a hooded kind of IVL, because I feel that when the calcium is eccentric, it's not completely concentric. If one could actually limit the the pulses of the ultrasound to one side of the vessel, we could probably improve the kind of plaque modification that we could do. So I'm trying to talk to see if we can get a hooded kind of a balloon, that is one half of the balloon hooded, so the ultrasound wave doesn't go out and gets reflected back, and you can actually create a little bit of an energy pocket which will kind of disrupt the calcium and make it easier to modify. I don't know if it will work, but let's see. I mean, it's just an idea. But
those are all great suggestions. We obviously should talk. There's lots we could talk about. I'll just address in a couple of those points. Firstly, there's some data coming out in IVIS showing that you can actually see reverberation artifacts when calcium is thin. So that's encouraging sometimes. Secondly, in relation to your hooded point, I think that's a great idea. I'm not sure it'll work for IVL because the wave reflection is so short that actually we're doing some work with Shockwave at the moment in terms of their educational materials and so on. But the summation wave, i.e. the reflected wave plus the original wave, doesn't seem to amount to very much. But interestingly, I've also thought of this as an idea too to address eccentric calcium. There has been some work done on laser with exactly the same idea, using a hood and using the hood as a kind of way of targeting the laser wave. And I think the laser also has an equivalent waveform of about 60 atmospheres in terms of modifying calcium too. So that may be something down the line as well. But I'm also an enthusiast for using cutting balloons. I think there's a lot you can do with existing therapy. It's a shame that lithotripsy is so expensive in India, and hopefully, there can be a solution found for that, because I would say I've spent the last 15 years in complex PCI, and this is the single most disruptive technology in a positive way that I've used in 15 years. And I've done 300 CTOs a year. That would be, so I do a lot of complex work. So, and I think it's a proper game changer for severe calcific disease.
Dr. Kasturi, you have any comment?
Thank you very much, sir, for a very nice, and it's a very educative and informative talk. We learned many things through your lecture. Really, you added value to it. Really, I'm very, very thankful to you from the bottom of the heart. With short notice, you could accommodate your time,
Pleasure.
your precious time. We appreciate you very much. And I have
enjoyed it.
Actually, there are some case reports when you have a side branch, particular bifurcation lesions. We also did some cases, but because you have a lot of experience about the IVL, I wanted to know if the side branch is diseased, you can put the IVL balloon in the main vessel and NC into the side branch. And if you give the IVL pulses, and there are case reports, and it's also recommended, it will transmit the waves into the side branch ostium also. What is your experience about this? Is also the losing the side branch. The phobia is not there with IVL. That is one of the greatest advantages. Not only why you can keep the balloon also. Can you share?
Yeah, no, it's a great question. And actually, the morphology of bifurcation disease is such that the carina is often spared from disease. And the problem when you have eccentric calcium in the presence of a side branch is the side load. The side load dissipates the force. That happens with conventional balloon therapy as well. So you balloon, and actually the balloon bulges into the bifurcation and it doesn't modify the plaque. So that's something we adopted with IVL quite some time ago, to put an NC balloon in parallel to do a kissing to start with. And it just makes mechanical sense irrespective of what it does to the waveform. And I think nobody really knows what it does to the waveform, but it certainly doesn't seem to cause a problem. And whether it results in augmented modification, I think is very likely, but it's a kind of thing you're going to have to do at a bench test. And then it's going to be very difficult to quantify it within a clinical scenario, because there's no randomized way to randomize that. You're going to have to say it requires, whatever, 10 pulses with a balloon in place as opposed to 50 pulses with a balloon out in place. It'd be very easy to do bench test wise. It'd be very difficult to show that difference clinically, but I think you're absolutely right. The side load of a bifurcation creates all sorts of issues, even in CTO PCI it creates issues. And I think it's pretty appreciated, but that's exactly the reason why. This is one of the reasons why. Yeah, go for it. I was just going to say, this is one of the reasons why I love coming to India meetings. It always has such great questions.
So just another point about eccentric calcium. I was just wondering if it's possible to do a bench test to put in a stent and then see if it will modify eccentric calcium. So the problem with eccentric calcium or less than, it's just an extension of the hooded balloon idea, that if you actually have a stent in place, it might actually help us, because I saw on a live case somebody modify an underexpanded stent with an IVL balloon, and then it struck me that if you have concentric calcium, it works beautifully. Our experience is in single digits, but it's really great. But if you have eccentric calcium, you're really stuck. So I just wanted to know if there were any bench tests that you put in the stent and then see if it actually modifies the eccentric calcium, because it would be a very big tool.
Yeah, you see, Shockwave are very twitchy about this, because again, it was me who described the first in-stent use of Shockwave as well. It was me who published that, but they're very, very twitchy about it, because it encourages lazy practice, and there is some just shove a stent in, and if it doesn't work, then use lithotripsy. And the second thing is, they have some bench data which they won't share, showing that it leads to excoriation of the stent. It removes the outer surface and the polymer and leads to this pockmarking of it. Now, they talk about this, they've never shared it. Whether it's a real problem or not, I don't know. But I think with fresh stents, it's a relative contraindication, I guess. So I think you probably should be sticking with plaque modification and then stent implantation, because if we tell people just put a stent in and then use Shockwave, we'll get all sorts of dog stinners.
How often do you use halfway rota compared to regular rota, particularly angulated lesions, very tortuous lesions? Nowadays, the people are preferring the halfway rota instead of doing the full rota.
Do you mean at half the speed or?
Yeah, half rota.
Rarely. I have to say, I always cross at normal speed, so 160 usually, and make sure I can cross and retract the rota safely before we do anything different to that. And then, I probably will go down to 110 PMs and not much lower than lower than that. Now, that's not data-based. That's, I've seen all the elliptical stuff that Yoshi and his colleagues have produced in Japan, and clearly that makes sense. But I think with rota, you're always slightly half aware that you don't want to get a burr stuck, because if you get a burr stuck, that's pretty unpleasant. So I want to make sure I can cross it and ablate at least first of all before I'm going to drop the speed. And clinically, I generally haven't dropped it any less than 100 RPMs.
I have one last question. So how many times do you use guideliner and all when it doesn't cross, when your IVL balloon doesn't cross? Do you use techniques like buddy wire, guideliner and all that, your IVL balloon cross?
Of course, you're getting a slight window into the dark mind that is. I don't really use buddy wires anymore. I just think they're defunct. Of course, I used them ages ago, but now not so much. Guide extensions again are big change in complex PCI. We can't do complex PCI without them. I would say that if you're really struggling to get an IVL balloon in place, you probably should modify the plaque before you do it. Because again, there's some data to suggest that the closer the transmitters within the balloon are, the less effective they are. So I don't think you should be really shoving the balloon in and then just try to use it like a semi-compliant balloon. In those kind of cases, we're usually using rotational atherectomy first and then using lithotripsy if we have to, because first of all, it crosses less well. And secondly, it performs less well. And certainly the early iterations were rupturing at that stage. So you weren't really delivering the force and actually, of course, you're wasting the money at that time as well.
Thank you. Dr. Sridhar Kasturi, you have anything?
I think today we had a very great session, and thank you each and everyone. My special thanks to Dr. James Pratt, Dr. Anand Rao, Dr. Ajay Swami, Dr. Sujata, and Dr. P.K. Sahu, and Ramesh R.K. Jain for contributing immensely to this academic program. And at the same time, I also I thank each and everyone who participated in this program, and request all of you to join tomorrow morning by 9:30. Tomorrow also we are having 2 live case transmissions, many case-based complex PCA. Thank you one and all, and have a great night. Thank you.
Thank you very much. Bye-bye.